मॅडमची स्लाइड दिसली का?
नाही ना, तेच तर त्याला विचार.
मी शेअर नाही केले. मी शेअर करू का?
नाही, तुमची इंट्रोडक्शनची स्लाइड तुम्ही पाठवली होती ना मॅडम?
हो हो, मॅडमने पाठवली.
सचिन जरा ती शेअर कर ना मग. हा, ते ओपन होईल बघ आता.
आली, शेअर झालीये.
शेअर स्क्रीन झालाय, पण त्या स्क्रीन वरती तुझं हे दिसतंय, सगळ्यांच्या सीव्ही लाइंड अप केलेले फोल्डर दिसतंय. The CV is not visualized.
Sir, on my laptop, no, it is visualized.
Then तू काहीतरी सेटिंग्स मध्ये इश्यू आहे तुझ्या.
सुमित, एक मिनिट, दीपेनला फोन कर आणि त्याला ते जरा हे करायला सांग. टीमिंग ने करतो, तर टीम व्ह्यूअर करून तो करू शकतो, तर दीपेनला सांग.
I can see all the things. हेलो,
आपको एक बार वापस स्टॉप
क्या हाँ ओके ओके, स्टॉप कर रहा हूँ. ओके, स्क्रीन कर रहा हूँ. एंटायर विंडो कहीं नहीं आया, शेयर आया सिर्फ.
गुड आफ्टरनून मीनाक्षी सुंदरम सर. गुड आफ्टरनून.
देखो,
हाउ आर यू सर?
देखो स्क्रीन आ रहा है, वेब जोन सेम ही आ रहा है.
सर, यू आर म्यूटेड. यू आर म्यूटेड. सर, you are muted.
WhatsApp.
Madam, I think Pune is flooded.
Yes.
Now it's
Flooded of rains and flooded of academics, both.
कुछ नहीं.
That's nice.
Yeah.
Good afternoon, sir.
अभी
Good afternoon.
क्या? ओके. हाँ, कर दे.
Yeah, we can see now.
आप देख रहे हो?
Sachin, we can
मुझे
see your
दिख रहा है.
Madam slide we can see now.
हाँ, ठीक है.
I can start now.
Dr. Sachin, we can now see the screen.
Yeah.
Fantastic. Thank you.
You can start, Sachin.
Madam, 3 minutes are there.
Yeah, we are given time for 4:15. You start on 4:15, I think so. Many participants have joined. Okay.
Okay.
Attendees are 103 and panelists are 11. Yeah, you can start.
Yeah. We can start. No problem.
Okay.
Madam,
Yes.
slide share.
Yeah. Am I audible to all of you?
Yes.
Yeah. Okay. The very good and warm welcome to everyone assembled here. I am Dr. Sachin Wag, who is your host today's online webinar along with the Dr. Varsha Kurade. I welcome to all participants and especially very thankful to our respected speakers, Dr. Pradnya Sawant ma'am, Dr. Sandeep Diwan sir, Dr. Vikas Karne sir, Dr. Meenakshi Sundaram sir, Dr. Anju Gerwa ma'am, Dr. Madhuri Kodi ma'am, Dr. Lipika Swain ma'am. Thank you so much for with us. Now I would like to hand over the platform to our dynamic and very enthusiastic SAPC President, Dr. Maya Balarao ma'am, for the welcome note. Over to you, ma'am.
Yeah, you can close this slide, Sachin. Yeah. Good afternoon.
Yes, I closed it.
Yeah. Good afternoon, respected faculties, SAPC members, dear students, and delegates. A very warm and hearty welcome to one and all from SAPC and DYP team. Since 2 days, we are celebrating the Festival of Academics, Festival of Knowledge, and that is ISA National West Zone PG Assembly. And it gives me immense pleasure to share with you that we received 350 registrations, and out of that, 200 are the students. For the inauguration program and for all the day 1 and day 2 program, we received fantastic response. Dr. Anjali Bhure, Vice President, ISA National, Associate Editor of ISA National, Dr. Bajwa, Kuminder Bajwa, MSc ISA President, Dr. Manisha Katikar, MSc ISA Secretary, Dr. Avinash Bhosle, they had graced the occasion. Day 1, that was on Saturday. It was by 9 lectures. We had 9 lectures by all esteemed faculties. And that day we had 72 e-posters presentations on 6 plasma TVs. And it was a huge program. We started at 8 o'clock and then it got over by 8:30. Day 2, again, we had fantastic response and we had 6 workstations at DYP Medical College. That was arranged by Dr. Chaya Suryavanshi, HOD, Anesthesia Department of DYP. And that day, yesterday, we had 65 podium presentations on 6 screens. Both the days, we started these programs at 8 o'clock and it got over by 8:30. So you can see the amount of response and the huge work we had done since 2 days. And cherry on the top was the simulation workshop, which we had arranged yesterday along with this PG assembly for the consultant. It was simulation workshop was arranged by our branch, and we had invited Dr. Sunil Pandya, Dr. Ketan Parekh, Dr. Manok Nath, and our team was there to facilitate the program. That simulation workshop was on high-risk obstetric anesthesia, and to our great happiness, we received 150 registrations, and it was again the great show. So this is a last session of our PG assembly. We have stalwarts with us, Dr. Pradnya madam, very dear to our heart, Dr. Meenakshi Sundaram sir, Dr. Vikas Karne, very close friend of mine, and Dr. Lipika, Dr. Madhuri. We are really blessed to have you all with us. And without any delay, I once again extend my warm welcome, and we'll have a very nice session. Over to you, Sachin. Thank you so much.
Yes, thank you so much, ma'am, for such a valuable words for us. Okay, now we feel very honored to have with us Dr. Pradnya Sawant, ma'am. She is the head of Department of Pediatric Anesthesia from BJ Wadia Hospital, Parel, Mumbai, and she is going to present our next topic. Over to you, ma'am.
Okay. Hello, everyone. Hello. Can you see me all?
Yeah.
Hello?
Yes, madam. Yes.
Am I audible?
Yes, ma'am.
Yes, audible and
Yes,
visible
yes.
both. Yeah.
Okay. So first, let me congratulate you all people, SPCA, and actually, I really missed the conference, the physical conference, but definitely I can, make some other time to meet you all. First, really congratulations for having a huge success of this PG assembly. And actually, it is needed for, for the those who are, studying, and you have given them really very, very vast experience. It's really very nice. Thanks to you for inviting me also. And I hope I will do my justice to, for my topic. Okay, so shall I share my screen?
Yes, madam. Yeah, yeah.
Yes, ma'am. Yes.
I think Grewal madam had joined. Anju Grewal madam. Welcome, madam.
Welcome, ma'am.
Okay, okay. Can you see my screen now?
Yes, ma'am. Yes.
Yeah.
Yes, we can see.
Okay.
Yes.
Okay. So actually, Dr. Maya Jadhav, she requested to me to speak on the regional blocks, which is a quite a popular topic. And this my presentation is I have modified because it is a PG assembly. Okay. So this will be like basic things they should know because they are still yet not qualified. And what they should know, I'm not going to talk about the very high blocks which they are not supposed to know at this level, but basic things they should know before doing these blocks in their practice. At least they can have some glimpses. Okay. So greetings from Vadia Children's Hospital, where we do a lot of these blocks, and all the students, okay, those who are interested, they can definitely come here and learn during our workshop, or during our fellowship, or they can come as an observer, and they can definitely learn these blocks. Okay. Now, when usually they have been asked either in the practical or in the theory session, they ask about these pediatric regional blocks or any regional blocks. But personally, as an examiner, what we expect them to know, one thing is how points to be learned, also points to be written in their theory examination should be like introduce the block, you write indication, contraindications, you write anatomy of the block, the position of the patient, how you are going to give the position of the patient, the technique and various approaches if they know any different approaches, equipments, what they require for that particular block, performance of the block, how do you perform that block, then what local anesthetic agents you are going to use, their doses and their adjuvants, and if they are using continuous block infusions, then you write about their complications and the treatment and how do you prevent those complications. And at the end, you can write the whatever like their advantages and whatever the disadvantages of these blocks. So this is a whole entire thing. If they are asked to describe, sometimes they ask a single block, or if they want to know the more about the entire thing, this is the points to be written during the examination. Now they must know the whatever the relative difference between the adult and the pediatric patient when they are learning these regional blocks. So first of all is the anatomy. The target nerves are very small and they're very close to the vascular axis, or say in the skin. So the depth of insertion should be a very sensitive, or very low. It should be immediately, because the loss of fat and loss of muscle development, they don't have to go too much of in. Okay. So they have a delayed development of the spinal curvature that has an advantage over, putting the catheter to the caudal, so that they straight away from the caudal catheter that can, reach to the thoracic levels. They have a delayed myelination of the nerve fibers. Okay, so if they have a delayed myelination, the local anesthetic reactions are quite different. That's that you should know. Physiologically, liver phase 1 and phase 2 are decreased, and the renal GFR 30% of them are added. So basically, those who are metabolized by the liver, that can have a local anesthetic derange, or say decreased clearance. Okay, that's the one point. Pharmacologically, the protein binding and the clearance is very important, because albumin and the alpha glycoproteins are quite decreased. So they have a free albumin, free drug of local anesthetics, and which can cause easy toxicity in these, especially in the neonates. So that you must take care of, not to have a toxicity in a small child. Now, indications, obviously, like orthopedic adult patients, you have all indications like orthopedic patients, urology, general surgical procedures, patients with full stomach, those we are with a malignant hyperthermia. It can be adjuvant to a GA in a major procedures, major surgical procedures, for the prolonged procedures, both for the intra and the post-operative analgesia. So the requirement of the general anesthesia is very less, and the endocrine diseases like diabetes, hypertension, they are quite useful. Okay. Now, what are the contraindications? You have some absolute contraindications like a coagulation disorder, severe coagulation disorders. You should not be giving the unless it is gets corrected. Septicemia, meningitis, space occupying lesions, spina bifida, allergic to local anesthetic, lumbosacral anomalies. That is because you can damage the structures, hydrocephalus, craniosynostosis, because increased ICP that can have various deleterious effects. Relatively, if there is a kyphoscoliosis or previous surgery of the spine, definitely the more number of modern gadgets you can definitely give central neuraxial or peripheral blocks. The surgery of the spine and uncontrolled seizure. So once you control the seizure, I don't think it is a contraindication to do block. Now, pediatric regional blocks are divided into central and the peripheral neuraxial blocks. The central neuraxial blocks are mainly epidurals at various levels like caudal, lumbar, thoracic, and the cervical. And in central neuraxial block, we have a spinal. So we will be talking all these blocks, obviously peripheral blocks also I'm going to talk. Now, what are the caudal blocks indications? The indications are obviously, again, whatever the neuraxial blocks of the lumbar epidural or spinal, these are the same. So septic disease of the lower limb, chronic pain of the lower extremities, prognostic or diagnostic therapeutic nerve blocks. But specific contraindications are major malformations of the sacrum. Usually it is contraindicated. As said, meningomyelocele, infection at a site of the sacral area, and sacrococcygeal teratomas. Obviously, the sacrococcygeal teratomas, you can definitely go above the, you can do a lumbar block, the caudal block, but sometimes may be difficult. Now let's come to the caudal block. So the caudal anatomy, the adult and the birth at patients who are with the neonates, especially the caudal anatomy is different. You can see the the shape of the coccyx, the level of the spinal cord where it ends. It ends in adult at L1 and it is at L3. So problem is like, and dural sac also ends quite low. Okay, so while if you are puncturing the caudal space, you may puncture the dura and can cause a CSF leak. So that is very important thing, the important thing in a caudal space. So what is a caudal space? A caudal space is a triangular shape. This is a caudal space. Okay, so triangle, these are the upper cornu and this is the lower cornu. The triangle is formed by the posterior, superior, inferior iliac spines. Okay, so if you make an equilateral triangle, the apex is obviously a caudal space. Okay, so this is like a surface anatomy. These are the two upper and the lower cornu. And see here what you should put. Your finger, you enter your needle, simple hypodermic needle inside the skin, and then once you pierce the skin, you can lower down at the 30 degree and you can enter the floor space. And in this my presentation, I'm not going to show you the videos because it takes quite a long time and they might have a limited time period. You can definitely go for the videos in the later on. So what are the local anesthetic agents? You have Armitage formula, very comfortable, convenient formula for this. As you go at a higher level, at a lumbosacral level, okay, the volume is more. Like mid thoracic, it is 0.5, it is lower lumbar, it is 1 ml, and depend. So what type of surgery is there? So upper thoracic or say lower thoracic or say lumbosacral or sacral surgery, depending on how the sacral volume should be given. So maximum volume about you should give a 20 ml and you should not exceed the more than the 20 ml in the caudal space. Okay, I'm going to talk about the local anesthetics later on. Now, if you are going to have a major surgeries and if you want to have a continuous catheters, you can definitely put a catheter. Here you have put a simple hypodermic needle, and if you have a simple tape catheter of 18 gauge, which is quite a stiff and good catheter, you can use it. You can use a definitely 19 gauge catheter also. And if you want to have thoracic patient, you can measure skin to a space dermatome at what level you want, and straight away you can insert the catheter at that particular length. You can insert the catheter. Now this particular thing I'm showing, because in the neonate this curvature is not developed, anatomically this curvature is not developed. Okay, so it is always straight. Even if you see the all vertebrae are, most of the places are straight. So you can, if you put a caudal catheter, that can go straight away inside. That is the beauty of so in the neonate don't have to go for the lumbar or the thoracic. You can catheterize through the caudal catheter. So suppose if you have already catheterized, and you don't want in the sacral area, if you have a surgery, you can do the tunneling also, so that it does not come in, because you are dressing and then all these things, it does not come in your surgeon's way in operative field, and you can do tunneling so that it does not get sepsis and infection. That you can do for the other procedures, sacral procedures, because bladder and the bowel are quite close, so it should not get infected. Now, both these caudal and the lumbar blocks, usually you can give with ultrasonography graphically. And then if you can see, this is G2, this is frog's eyes. If you can do stage, then you can definitely go and you can definitely, be confirm that it is going definitely to the caudal block. And same thing, you can use it in a lumbar block also. Now come to the lumbar block, epidurals. As we have said, you must know the anatomy, which dermatomes are, in what level you have T1 to T2 to T11, okay, till L1. So these, which lumbar blocks, segments you must know. So these lumbar blocks, you can give either single shot or you can put the catheter. Okay. So in a single shot, you take a 19 gauge or 18 gauge numbers in a smaller children. In adolescent, you can use a 16 gauge, but most of the time we use a 18 gauge catheter. Okay. So 18 gauge catheters and the 19 gauge, that will not have a, pericatheter leak or say perineural leak. So, okay. So that is why you should go for the smaller number of needles. Okay. The it is a loss of resistance. How do you detect the epidural space? It is the same way in a adult patients, but because of the loose fibrolar alveolar tissue, the feel of the tissues compared to the adult and the pediatric, it is different. So you have to go very, very, very carefully inside. You see the one hand will continuously go in, push the needle inside, and the second hand will give a positive pressure. And for this loss of resistance, we always use the saline. We don't use the air like in an adult patient, and we don't have to keep on pushing the lot of air inside, because that will cause a lot of patchy bulk, or sometimes if your vessel or if your needle is in the vessel, that can cause the air embolism. Okay. So now once you pass the catheter in, you should know the skin to epidural space and how much inside you want to keep, depending upon the type of surgery. So whether it is upper abdominal or the lower abdominal. Okay. So these are the some needles which I have shown. This is 19 gauge, or say these are the 18 gauge. You can have a different color codings, but you both only 19 and the 18 gauge should be used. So the guidelines to determine the epidural depth is, it is a 1 mm per kg of the body weight. You have the various formulas, so you can definitely, but be careful while in the children while going, because once you go in a too much of weak level, a lumbar level, you can damage the spinal cord. Okay. What are the approaches? Approaches is always a midline. Okay. Very rarely paramedian approaches are used, especially those if you are very much experienced, having giving a lumbar block in a pediatric patient, and if you are unable to give a midline because of spinal deformity, then only you should give a paramedian. Otherwise, what are the position? You can give a lateral decubitus always. Okay. Because these patients are small patients, and unless and until you put to the stick, they won't allow you to enter. Elderly children like 15 TV, you can persuade them and then make them sit and give a caudal block, lumbar epidural block. Okay. So what are the other techniques to detect the epidural space? One is the loss of resistance. The second is a sudden case of ease of induction. It is not case, sorry, it is ease of injection to needle. Hanging drop saline into the hub and the ultrasonic localization. All these are the these are the for the therapeutic purpose, or just for the to write in the theory examination. Usually all these things are not practiced. So basically pushing the saline going easily, or loss of sudden loss of resistance. That these are the classical things you to note that, and there is no CSF or blood coming out, so that that it is in the epidural space. Okay. Now, pediatric epidural dosings are mostly the bupivacaine and the ropivacaine are used. You can use the dignocaine adrenal in the older children. You can have a single injection of less than 1 year old of 1 ml, and more than 1 year old 1 ml per kg, maximum 20 ml you should use in the caudal space. The continuous infusion also 0.1 ml to per kg you should be given, and you should not exceed the dose of bupivacaine. What are the additives? At the present, there are various additives are there, but the clonidine and the fentanyls are the most common additives are used. And obviously, they will have their own, narcotic side effects like, respiratory depression, hypotension, urinary retention. Obviously, they will also have a so very, very carefully. Very small children less than 1 year, the clonidine and the fentanyl narcotics should not be given, because they go in the respiratory depression in the ward. So be careful in this issue. Come to the thoracic epidural. That is the difference between the thoracic and the lumbar epidural is interspinous ligaments are very thin and the spaces are quite small. Okay, as such you find very small spaces. So the dura surrounds the spinal cord and the lack of feel of the tissue resistance. It is quite a difficult and a dangerous. So sometimes you may have to give oblique insertion in the needle for the older children, but in the smaller children, all the vertebrae I have shown you in the X-ray, they are nearly horizontal. But in a smaller children, the thoracic is not practiced very because it is quite a detrimental to the or say damage to the spinal cord. So preferably older children you should use, smaller children you should not use. Strictly midline approach and the insertion of the needle should be in a that which I told you just now. What are the indications? Indications: upper abdominal thoracic surgery, and it should be used only in the elective surgery. It should not be used in the patients who are in the sepsis or in the emergency surgeries. We usually avoid these surgeries. Like anatomical landmark, you can go from the T4 to T7 level. Usually for the for thoracic cases in the younger children, we use the upper lumbar, like T10 to L1, so that we don't have a complications in the surgery. You can use the bupivacaine. Mainly we use a bupivacaine or ropivacaine 0.1 or 0.25%. The dose is usually it is the smaller. It is a 0.3 ml. We don't require a higher dose in using. Complications are the damage to the spinal artery. By any means, you should avoid that can cause the ischemia of the cords. It should be the strictly midline approach. I have already told you. Now, this cervical epidurals in adult it is practiced, but in it is potential morbidity is enormous. So in pediatric patients, it is not practiced. In a smaller children, definitely not, but you can definitely use in a older patients like those who are patient with a stage segmental scoliosis surgery or with a muscle scoliosis of neuromuscular origin. So that definitely sometimes they do this SSSA, that is stage segment scoliosis surgery. Cervical epidurals are given, but it is very less. Okay. Come to the spinal, that is a quite interesting neuraxial block. This is indications are mainly usually the spinals are, I know people like the spinals, but usually we indicate them, patient with the premature babies with the apneic spells. So we don't have to give a general anesthesia and cause that the post-operative apneas are avoided. Floppy baby syndrome, neuromuscular diseases, or any respiratory reserves or place, or patients who are with a respiratory distress syndrome or malignant hypothermia, patients who are with the hyperthermia, older children. So these patients, they are classically indicated to give a spinal. Contraindication, absolutely infection of the site of these things, and ICT or any intracranial bleed, meningitis. Relative, obviously, you can definitely correct them. Any contraindications are there, or surgical procedure of long duration, because the spinal effect on the small children remains for a shorter time, obviously. So for a long duration surgery, spinals are not advised. Okay. So this is basically I want to know how the things adult and their variations in their sizes and body sizes. So if you have an idea about that, what level adult and the pediatric patients variation of the size of the body parts are there. So that can give you. So what are the difference in the anatomy? I have already told you the dura ends quite low. Even the spinal cord ends quite low. So you don't have to give a upper level spinal anesthesia like at lumbar level, because that can cause a spinal injury. Okay, spinal cord injury. CSF volume is more. That is why you require a more drug. Okay, CSF production is more. Certainly, that is why the metabolism of the drug is very fast and the duration of this duration of the local anesthetic is very low. Okay, nerves are thinner, so be careful giving the spinal in the small children vessel. Beauty of the spinal anesthesia is all these things are quite immature. Peripheral resistance is low, small volume, extremity compared to adult patients, and block. So the hypotension is quite low in these patients. Okay. So what are the lateral, or you can give a, but be careful in these children that you keep their airway patent. Okay. And you have these spinal needles, the spinal needles to be given as depth of the insertion. You don't have to keep on going inserting needles. So use the stiletted needles to prevent, and use the small syringes so that exact volume of the spinal you can give. Local anesthetic volume, as I said, smaller the child, more the volume. Okay, because the CSF volume is more and the metabolism is fast. So you can give a 1.1 ml per kg of heavy bupivacaine, what we use it. Okay. So no head low position and the apply monitoring system. You remember I have shown you the X-ray, because once you put a head low position, the entire drug can go in a caudal space and that can cause a scrotal spine. This is you can see the CSF volume. It is quite adult CSF volume, and the full term baby is quite high. So the metabolism distribution is very high. Complications, obviously, you can have various complications like adult fecal cerebral systemic toxicity or vascular complication and the spinal cord injury. Come to the peripheral block, you have a various block. I'm not going to talk because the time is very short. I'll detect a few blocks like upper limb, lower limb. I think upper limb blocks, so Dr. Is going to speak, Sandeep is going to speak on that, and he can elaborately talk on that. You have a truncal blocks, abdominal blocks, head neck face blocks, there are so many blocks, but we cannot complete it. What are the important? Anatomy is very important in all the blocks, as I said. Method of localizing the local anesthetic, locating the nerve is anatomical first landmark, usual paresthesias in the older children using now stimulator, mapper, and nowadays we use the ultrasonography. Now, commonly use a local anesthetic in this thing. We use both the lignocaine, adrenaline, bupivacaine, levobupivacaine, ropi, and it is more dilute solution used for the post-op analgesia. So one just want to know if the nerve is bigger or thicker, the more volume is required. Like in a sciatic, if you see the compared to the dose, the sciatic nerve will take the largest volume because it is a large volume. Okay, just remember that. Okay, now come to the upper lip block. You must know the anatomy or say distribution of their nerves, like from C5 to T1 and how their cords and everything are formed when you are describing. You have a various approaches, like one is a clavicle is the landmark, one is a supraclavicular and the intraclavicular approach you can have. Here the most easiest block in the pediatric patient is the axillary block. Okay, so in the axillary block you have a supine position with the head abducted, you see, and you must know not is too much of extension is required, otherwise you cannot palpate the axillary artery. Okay, so in this patient, so you can palpate the axillary artery and you just go above it and you can just see that loss of resistance is there because it is contained in the neurovascular sheath. And once you have a loss of resistance to your needle and negative aspiration of this blood, especially blood only for puncturing of the artery, you can inject. You can use the axillary catheter also for the prolonged surgeries. You can see these patients like how they are conglomerated, surrounding the neurovascular bundle. If you have definitely you can use ultrasonography around the artery. All these nerves are, this is very easy, absolutely easy block. Even if you don't have a ultrasound, you can definitely give, or you can use the PNS. The second comfortable or say safe block which in the pediatric patient is the infraclavicular. Usually coracoid approach is there below the clavicle, and you can use it in a patient's midline to the lateral to the midline, if you can say 1 centimeter below. And if you have a ultrasonography, definitely you can use this. This block is quite safe because the pleura, if you can see, the pleura is quite away from this. The only thing block problem is with you should not be puncturing the vessels. So be careful if you have a comfortable ultrasonography, you do not have to puncture. And surrounding this axillary artery or subclavian artery, you can definitely give this. Come to the lower limb block. Again, you must know the lumbosacral plexus, like from L4 to S1, and these are the various nerves. How the sciatic nerve is formed, how the sciatic nerve is situated in the X-ray. This is just a cross section. It is very close to the femoral nerve. Okay, so these are the various approaches are there. But this one of the approach which I'm going to tell you is very easy approach, because this approach can represent this line represent the sciatic nerve. It is emerges from the gluteal region, and this is at the popliteal region. It divides into common poplite in the tibial nerve. So this represent the tibia, this sciatic nerve. So along this line, you can definitely anywhere you can anesthetize these nerves. Now, if you have a ultrasonography, definitely you can use. It is very close to the femur nerve, and you will have a lesser volume. Here, if you are using arbitrarily, you can have to give a larger volume of this. Same thing with the femoral now, how the femoral structures are there, like, right from the pubic symphysis anatomy is to the anterior superior iliac spine. It is the midline, you have an artery, you can have a vein, artery, and the nerve. This is the vein, artery, and the nerve. The most lateral is the nerve. And you can definitely, do with a peripheral nerve stimulator or with ultrasonography. With the ultrasonography, so you classically you see femoral vein, femoral artery, and the femoral nerve. And you use a smaller volume of either ropivacaine, as which I have told you already in this. Next is another easiest block if you don't want to give a lumbar this thoracic epidural, intercostal block. The intercostal again vein, artery, nerve, same thing. It is just just below the rib. Any intercostal ribs are there. Just go below, turn into the 45 degree, and you can block these nerves at various levels. So the thoracotomy, this block is very useful if you don't want to give a thoracic epidural. These blocks are also practiced paravertebral, quadratus lumborum, and the erector spinae in a small children. We do practice for the and the tab block. Of course, I forgot to have umbilical, any supraumbilical surgery. The tab blocks are also quite good in small children. You use it so that you avoid the central neural shield block. Okay. Now come another is the easiest block which can give children who are coming for the commonly for herniatomy, they usually come. So here all the nerves are passed through the anterior superior scapula side medially and 1 centimeter below. So these are the classical nerves are emerging, and this is a classical point of entry. So here if you see the classically you can use either with a pop-up technique, means for 2 muscle layers or say layers of abdomen. So you just do a pop-up technique, or you can use ultrasonography to know the classically this transverse abdominis muscles, and to deposit there in the classically in the this ilioinguinal and the iliohypogastric nerve. Now, how much dose to be given? Dose is from age to adult phase, 3 to 6 ml per segment you can use. Up to 15 to 20 ml, adult patient, you can use it. You can use an additive in these patients, definitely you can use. Now, another is a very simple block is the penile block, which is used for the circumcisions. If this is one of the block you can use this, like the penile, 3 types of or 3 approaches are there. So in anatomy, you have a pudendal nerve going from both the sides, and the dorsal penile nerve from the behind. So what you have to puncture here is the Buck's fascia. So what you just go above this pubic symphysis and put your finger here. This is the finger, and just go below the pubic symphysis intra. So you Buck's the fascia. This is the potential space where you can deposit your local anesthetic solution. Or this is a one method. This is a one single method. You have a 2 methods, like approaching from the 2 sides. Okay, from the 10 centimeter 10 o'clock position and the 2 o'clock position. But then again, the chances of the dorsal penile artery is quite high. So preferably we can use this method is comfortably. So, and 1 ml of ventral surface, you should use it to block the pudendal nerve. Okay. The problem with here is important is you should not be using the lignocaine adrenaline. Okay, anywhere in the finger or say terminal stage, arteries, you should not be using adrenaline, because that can cause a vasoconstriction, or they can get absorbed, and penile ischemia can be. So please avoid this. Now, another very important block is the infraorbital nerve block is there, which can be used for the very good useful block for patients who are having a cleft lip and palate. So all these 3 foramina, like a supraorbital, infraorbital, and the mental foramina, they are in a one line. So if you draw the line, you know and these are exactly coincide with the pupil. Okay, so if you see this is you palpate the infraorbital margin, just below that this infraorbital nerve emerges from that is foramina. So there are 2 methods of using this. One is the one transcutaneous, from how you palpate the infraorbital notch, and just below that you go in that foramina and you can just deposit the nerve. You can deposit bilaterally, or usually your surgeon deposits intraorally. Intraorally means you lift up the flap after the patient dripping and giving, and go towards the left eye. Okay, pupils of the left eye, exactly. So here it is a deposition of this is usually it is given by surgeon. This is usually we give us. Okay, So 0.5 is bupivacaine is 1 to 2 ml usually suffices. Okay. Now there are other very good blocks are there. Use a dental block. Usually the children, they don't allow, only with a block, but this, if you combine with the general anesthesia with a block, your post-operative pain management is quite good for the dental patients. Okay, so you tell your dental surgeon to give a block this is intraarterial block. Similarly, the patients who are simple cataract on surgery, if they give a retrobulbar block, usually the surgeons are give, but you need to decide the dose, okay, because they keep on adding. So for a small child of say 1 year or 2 year for a congenital cataract, that can cause a toxicity. So you see to it that these doses are absolutely within their limits and according to their body weight. But these are very good blocks that can post-operatively the patients are very comfortable. Now, what about without this local anesthetic toxicity, we cannot complete the regional block. So you have a characteristic classical presentation. Usually most of the children are under anesthesia. So what they will not tell you, okay, that, okay, I'm having a, confusion, I am, unable to talk. So direct symptoms are usually loss of consciousness. Sometimes loss of consciousness, obviously, sometimes they are elder children, those who are with a sedation. Okay, they suddenly lose the consciousness. They can have a seizure, they can have a bradycardia if cardiovascular symptoms are there. Depending what toxicity is there, you will have a symptoms, whether it is a cardiovascular or whether it is a central nervous system. So accordingly, you will have these things. So first of all, you must know the protocol. What is the local anesthetic stop? That is last management of the last. Ventilate the patient. This is as good as it is arrest, call, infuse the intralipid infection. If the patient remain unstable, again you have a cardiac resuscitation should be there, and if patient is stable, infuse intralipid for additional 10 minutes and the monitor for the recurrence. These are the very important, because if the children does not give you a very, so these algorithms you must know, especially when you are using. Now, without monitoring, you should not be using this block. You must monitor oxygen saturation, their ECG, especially like arrhythmias for the toxicity. Immediately you will come to know NIBP, hypotensions, respiration, loss of, apnea, patient. Apnea detect monitoring when the premature child is there. Temperature, because it is exposed part, central neuraxial blocks will cause a vasodilatation, then the drop in the temperature. And obviously, it is not that, you just you give a caudal block and you don't have to, you give some fluid, because you never know their, hydration status. So most of the children, you must give, food, hydrate well when you are giving the central neuraxial blocks. Now, in summary, I must say these eye blocks are quite safe unless you know them, how to give them. They are easy to perform, because persistently, if you give, they are very comfortable to give. Very enjoyable to give, then they have a minimum physiological disturbances unless you do something, havoc things. They are very extensively, you can enjoy the children post-operative, they are comfortable. They allow the prompt return of the post-operative feeding schedules of the children. So post-operatively, you don't have to knock down with narcotics, and they don't take away anything, So they are very comfortable post-operatively. They can start eating, and this very good post-op analgesia. Okay, so actually there are very good advantages of this pediatric regional, and they are extremely enjoyable. You can come wherever the workshops are there, you just enjoy these simple blocks are there without any much complications. Don't get get scared how to give these blocks. If you know your anatomy, if you know your what to drug give, if you know your dose and you know technique and their complication what can occur, these are the quite safe blocks to be given in this patient. So actually, thanks a lot, but I have taken liberty to take Maya madam's picture to give a thank. They're so beautiful, so beautiful. Maya, this I have just tempted to put these pictures in my presentation. Thank you very much. Thank you very much.
Okay, thank you so much.
Madam, my pleasure and honor. Thank you so much, Pradnya madam. Thank you.
Thank you very much. Yeah.
Thank you. Thank you.
Okay, thank you so much, ma'am. We are really fortunate to have your valuable guidance for our PG students as well as consultant for their great future. Thank you so much.
Thank you very much.
Yes. Now I would like to welcome Dr. Venkat Giri sir. You're welcome, sir.
Hello.
Hello, you're welcome, sir.
Thank you.
Good
ते
afternoon,
न्यायला
sir.
सांग काय ते करा. लवकर सांग कारण मी इथं आता.
Good afternoon, Giri,
Thank
sir.
you,
Yeah,
Dr.
we'll like
Maharaj.
your few words to encourage PG students, sir. Please go ahead.
Yes.
Sachin, thank you very much for the time. Sorry, I was not able to reach physically day before yesterday. I was held up. So today I'm very happy that I could participate with you in this online program. And it's opportunity for all the PG sitting inside to attend this program online. Though we have come down from the online program to more of physical. Today's program is online after 2 days of physical program, so that people who are away also can join and learn more. Because many times on a working day, you will not be able to join, get the leave also. Today in the afternoon, maybe you might have all finished your work and now free and attend this workshop. I heard that Dr. Srimas talk very nice with the good illustrations. It will be very helpful for the PGs. Next talks also will be so. All the best, and I wish you all the best for the program. And PGs will take note that this. And, thank you, Mayas, Sachin, and all in Impatient.
Thank you, sir. Thank you,
Thank
sir.
you, sir. Thank you, sir.
Thank you so much, sir. Thank you so much. It is our pleasure and honor. You have joined and you have blessed our students. Thank you so much. Over to you, Sachin.
Sachin.
Shall I? Yes. Yeah. Shall I move forward?
Yes, yes.
Our
Madam has
next
to stop
topic is
sharing her
AB.
slides. Madam has to stop sharing her slides, and then you can share
Yes,
the
ma'am.
other slides.
Deepen, are you there?
Yes, yes, sir.
Yes, please share the slide.
Have stopped?
Yes, madam. Yes, yes.
Yeah.
Seema,
Yes.
you have to stop it. I think you have given her link.
Dr. Seema
Yeah. I'm just saying.
shared.
You have given me the. Okay, fine. I'll see. I don't know what is. No, I'm not able to do it. Hello, Deepen.
Oh, I think
Yeah,
someone has shared. Yes, someone has shared their screen. Let me just stop their screen.
yeah. You. I don't know. Shared my screen. I'm not shared my screen.
Deepen, we can't hear anything.
Yeah. Okay.
Yeah, it's okay, Deepen. Yeah.
Sir, very warm welcome to Dr. Rajan Sancheti, sir. Sir is an observer today. And sir, thank you so much for joining.
Okay, thanks, ma'am.
Thank you, sir. Thank you.
Okay.
Okay. Should I move forward?
Yes.
Yes, ma'am.
Yes.
Thank you. Yes.
Yeah.
Our next topic is ABG and PPT, and it is present. It is going to share by Dr. Vikas Karne. Sir, he's a head department of the anesthesiology at Sayadri Super Specialty Hospital. Thank you, sir. Thank you so much, sir. Just over to you, sir.
Good afternoon, and
Yes.
I thank the organizing committee for giving me this opportunity to be here in front of so many PG students and all of you. As we have time constraint, I will directly get to the presentation.
Hello.
Hello. My screen is visible.
Yes, sir, the
it's
screen is visible. Yeah.
Go ahead.
Yeah. So I'll be talking about ABG and PFT interpretation. We'll begin with ABG interpretation. It itself is a vast topic, and I will not get into the basics of this because we'll be more focused on the interpretation from exam point of view. As we all know that the acid base and gas analysis is important to monitor the acid base balance, and it also help in monitoring the effectiveness of the gas exchange, and it guide us in establishing the diagnosis and also the treatment plan. So we will begin with this particular ABG where we have a pH. We have a pH of 7.38, PCO2 of 41, and bicarb is 24.7. And when we look at the range which is given next to it, we can conclude that it is normal ABG. So when we are thinking about ABG analysis, what we need to understand basically is the physiological and technical basics, which includes how the acid base is regulated, what are the three buffer systems, namely bicarbonate, respiratory, and renal, and how they work in acute and chronic scenarios, and what are the principles of ABG analyzer. And when we start thinking about the ABG, the steps that are involved is what are the indications for blood gas analysis, how do we collect the sample, what is the right technique, what is the right technique of transportation of the sample, how the sample is being processed, and how the report is interpreted, and then how the clinical correlation is performed, and the correction, if any, is planned. So these are the many steps that are included, but today we will be focusing, as I already mentioned, that only on the report interpretation. So when we look at any ABG report, what we see are the values, which can be grossly divided into 4 types: the values that we enter, the values that are measured and calculated, and the additional values. So the values that we enter, it's given at the base, are temperature, FiO2, and hemoglobin. And the analyzer will measure the values of pH, CO2, and PO2, and then we'll give calculated values about bicarbonate, base excess, oxygen saturation, and other parameters related to oxygenation, with additional values like electrolytes, lactate, and glucose. So this is how a standard ABG would look like. And when we take the ABG in hand in exam, what we need to do is first we have to confirm, then we have to validate, and then we proceed with the interpretation. So what we confirm it is the report of the right patient. So right patient, right report, done on the right time and right date. So as it is a dynamic investigation, we have to ensure that we are looking at the report which is valid at that particular point. Then we come to the validation. First thing that we see is internal consistency, for which Henderson-Hasselbalch equation is used. And what we are trying to do here is we try to evaluate the consistency of pH and H+ ions. So this is how the internal consistency can be tested. So at 7.4 pH, the H+ ions are 40 millimole per liter. And as the pH changes, the H+ ion concentration will vary. Once this is done, then we try and identify whether the sample that has been processed, whether it is an arterial sample or whether it is a venous sample. So if we look at these basic parameters which are described here, the pH, bicarb, and base excess, these are the parameters. We can see that in both arterial and mixed venous sample, they by and large remain same. But when we look at the oxygen saturation, PaO2, partial pressure of oxygen, partial pressure of carbon dioxide, we can see there is a gross difference between the arterial and mixed venous, and it is obvious. So if we are, the purpose of having blood gas analysis is mainly for the identifying any issues related to the gas exchange, we should be insisting on arterial sample. But if we are dealing with a critical patient, and we don't have arterial line, the arteries are not palpable, and we are struggling to get the sample. A basic venous sample, a VBG, would also help us to identify the metabolic status of the patient to begin with. And once we have proper line, probably we can have the arterial sample. So what I mean to mention here is in those patients where we don't have direct access to the arterial sample, a venous sample should not be discarded. So now coming to the steps for interpretation, for the sake of making it a little easy, we will have only 4 steps. We first look at the pH, then we'll look at the PCO2 and bicarbonate. Then we try and identify whether it is acute or chronic, if it is respiratory, and whether there is any compensation. So when we look at the pH, we all know that the normal pH is 7.4 with a range of 7.3 to 7.45. And when the pH decreases less than 7.35, becomes acidosis, and when the pH increases more than 7.45, it becomes alkalosis. Now we'll have a look at the PCO2. So PCO2 is 35 to 45, that is the normal range, with pH 7.4 being normal. Now we'll take one example. Here pH is 7.22 with PCO2 of 87 and bicarb is 21. So here CO2 is increased and the pH is decreased. So what we are looking at is respiratory acidosis. We'll take another example where the pH is 7.55, which is increased, PCO2, which is 30, which is decreased, and the bicarb is 22. So we are looking at something which is respiratory alkalosis, because pH has reduced and pH is increased and the PCO2 is decreased. Now, as we just saw this examples of respiratory acidosis and alkalosis, we need to identify whether it is acute or chronic. So for acute respiratory disorder, we have a formula to identify the delta pH. We use a fraction of 0.008 into delta of PCO2. And for chronic respiratory disorder, we use a formula where we use fraction of 0.003. So we are looking again at the same ABG where the pH is 7.24, PCO2 is 87, and bicarb is 21. So on the right side, I have given the formula for acute pH. When we use the formula with a fraction of 0.008, the value that we get is 7.03. And for chronic pH, when we use the formula with a fraction of 0.003, the value that we get is 7.26. So it is almost matching the pH that is there in our ABG. So we can consider this to be a chronic respiratory metabolic acidosis. Now we'll take another example where the pH is 7.21, CO2 is 65, and bicarb is 24. And with this, when we use our acute and chronic pH formula, for acute, what we get is the value of 7.20, and for chronic, we get a value of 7.33. So this particular ABG is acute respiratory metabolic acidosis. Now coming to the respiratory acidosis and alkalosis, we need to identify whether it is metabolic compensated or not. So when we are looking at the acute respiratory acidosis, in this particular case, the pH is 7.21 with PCO2 of 60 and bicarb is 26. So when we use the formula to find the delta HCO3, we use a fraction of 1 into the delta of PCO2, that is a PCO2 which is calculated, and the PCO2 which is normal, that is 40, and we divide it by 10. The answer that we get is 2, and when we add it to the normal bicarb, that is 24, the answer that we get is 26. So as the bicarb is 26, there is a compensation of this acute respiratory acidosis. The similar formula can be used for chronic respiratory acidosis, where we use value of the fact this here we use value of 1, here we use 4. So it is 4 into the delta of PaCO2, that is the difference between the given carbon dioxide and the normal carbon dioxide, and we divide it by 10. So in this particular case, we are getting a bicarb of 32 when the PCO2 is 60 and the pH is 7.36. This is again compensated metabolically. The same formula can be used for respiratory alkalosis, where we use a formula of 2 into delta of PaCO2 divided by 10. And for chronic respiratory alkalosis, we use this formula of 5 multiplied by delta of PaCO2 divided by 10. So what we are trying to do here is, for acute respiratory acidosis, we are using 1. For chronic respiratory acidosis, we are using 4. For Acute respiratory alcohols, we are using 2, and for chronic respiratory alcohols, we are using 5. So if we remember this formula, we can easily calculate the metabolic compensation, whether it is there or not. Now we will look at the bicarbonate. So as we know, the normal bicarbonate is 22 to 26 milliequivalent per liter with a pH of 7.4. This is the normal value. Now, bicarbonate actual is the actual bicarbonate measured in the sample, and we also get a value of bicarbonate standard, SCO2 standard. It is the bicarbonate which would have been had the PCO to be normal. So we most of the ABG sample standard machines, we get this value. Along with this, what we get is a base excess. It helps to quantify the metabolic component. So base excess is the amount of acid or base required to titrate the blood sample to the pH of 7.40. This is at the standard temperature and standard PaCO2 of 40 millimeter mercury. And the range of the base excess is -2 to +2. Now we'll consider one example again. Here the pH is 7.12, PCO2 is 23, and bicarbonate are 12. So as we see, the pH is decreased and the bicarbonates are also decreased. So this becomes metabolic acidosis. Another example where pH is 7.57, PCO2 is 37, that is normal, and the bicarb is 31. So here bicarbonate is increased and also the pH is increased. So this becomes metabolic alkalosis. Now, as we consider in the respiratory acidosis, here also metabolic acidosis or alkalosis, we need to find out whether there is any respiratory compensation. So again, we have similar formulas for metabolic acidosis. What we are using is 1.5 into bicarbonate, and we add 8 to this. And for metabolic alkalosis, we are using a fraction of 0.7 into the bicarbonate, and we add 20 to this. So when we use these formulas like what we used in the previous formula, we get the values, and that can be compared to our given ABG report, and whether we can find out whether the ABG is compensated or not. Now coming to the anion gap. So as we all know that we have anions and cations in form of sodium, magnesium, potassium, calcium, chloride, bicarbonate, albumin, and lactate. So the majority of this is sodium, bicarbonate, and chloride. So when we subtract the sum of bicarbonate and chloride from the sodium, what we get is an anion gap, and the normal value is 8 to 16 milliequivalent of equivalent per liter. This is clinically important to assess the acidosis. Now, metabolic acidosis based on the calculated anion gap, which can be either high or can be normal, can be divided into high anion gap metabolic acidosis or normal anion gap metabolic acidosis. There will be different reasons for high anion gap metabolic acidosis, which I think this mnemonic is very well known, that mud piles. And for normal anion gap metabolic acidosis, we have used scrap as another name, and all the conditions which can cause these two different types of metabolic acidosis I have explained here. Now we'll take this ABG where the pH is 7.15, PCO2 is 22, PO2 is 85, and bicarbonate are 8. So to find out whether it is compensated or not, we use the formula, because this is a metabolic acidosis where the bicarb is 8 and the pH is 1.7. We have used 1.5 into bicarbonate plus 8, and the value that we have got is 20. So there is a range of plus minus 2, and our PCO2 is 22. So this is a compensated metabolic acidosis. And then we try and calculate the anion gap. So this is where we use sodium, bicarbonate, and chloride, and the value that we get is 28. So this is high anion gap compensated metabolic acidosis. We'll see another sample, sample ABG where the pH is 7.21, PCO2 is 31, and bicarbonate are 15. So this is again metabolic acidosis with pH decrease and the bicarbonate decrease. We'll first try and find out whether it is compensated. We use the same formula, 1.5 into bicarbonate plus 8, and we get a value of 30.5 with a plus minus 2 variation. And the PCO2 that we have in ABG is 31. So this is again a compensated, and now we try and calculate the anion gap, and anion gap comes here 15. So this is normal anion gap metabolic acidosis, which is compensated. Just to make a note, if there is hypoalbuminemia, normal anion gap is 2.5 milliequivalent per liter lower for each gram per deciliter decrease in the plasma albumin. So as the albumin level goes down, the acceptable normal level of anion gap also starts going down. So if the albumin level is 2.5, then 12 minus 5, so the normal anion gap would become 7 milliequivalent per liter. We'll take a few samples. Here we are looking at the ABG where the pH is 7.17 and the PCO2 is 85, and we'll directly look at the bicarbonate. So actual bicarbonate is 31 and the standard bicarbonate is 24.3. We will be looking at the standard bicarbonate and comparing pH with PCO2. PCO2 is increased and the pH is decreased. So this is classical respiratory acidosis. This is another ABG where the pH is 7.21, PCO2 is 21, and bicarbonate, the actual bicarbonate is 8.4 and the standard bicarbonate is 10.5. So when we compare, when we look at the standard bicarbonate, which is 10.5 with a pH of 7.21, it is a mixed picture because PCO2 is also decreased. So there is a compensation. Looking at third sample, the pH is 7.53 with PCO2 of 30 and the bicarbonate is 25, standard bicarbonate 26. So this is respiratory alkalosis. So now we'll move on to gas exchange and oxygenation. So when we are looking at the ABG, we will get oxygen saturation, partial pressure of oxygen in alveoli. If we have a co-oximetry in our ABG analyzer, we will get partial pressure of oxygen in alveoli also. So when we look at the oxygen indices, what we can collect from these indices is what is expected PaO2, PaO2 by FiO2 ratio, alveolar arterial gradient, and arterial alveolar ratio. So we'll just go through these parameters because now we are looking at ABG of a patient who is hypoxic. So if patient is hypoxic, we need to identify what is his expected PaO2 and whether the value of PaO2 that we have received on ABG, whether it matches or patient requires oxygen supplementation. So expected PaO2 depends on the age, FiO2 and atmospheric pressure. But by and large, the PaO2 is calculated by 109 minus 0.4 into the age, and usually it ranges between 75 to 100 millimeters of mercury. So once we calculate the partial pressure of oxygen in arterial blood, we can calculate the partial pressure of oxygen in inspired air. So PiO2 can be calculated from FiO2 by multiplying the difference between partial pressure, atmospheric pressure, and the partial pressure of the water. So at room air, that is at 21% FiO2, the PiO2 that we can deliver, that we can gather is 150 millimeters of mercury. Now coming to the partial pressure of oxygen in the alveoli. So PaO2 is calculated by a formula where we use FiO2 and multiplied by a difference between the atmospheric pressure and the pressure of oxygen. And then we subtract PaCO2, which is divided by respiratory quotient, which is 0.8 or standard. So at room temperature 21% FiO2, the alveolar oxygen is 100 millimeters of mercury. Now coming to the alveolar arterial gradient. So this is again used to help differentiate between the different causes of hypoxemia. The normal range is 5 to 10 millimeters of mercury, or can be calculated from a formula H plus 10 divided by 4. If the gradient is normal, it could be related to the hyperventilation, neuromuscular disorders, or CNS disorders. And if the gradient is increased, we are probably looking at ventricular ventilation perfusion mismatch, or there is a defect in the diffusion, or right to left shunt. So at FiO2 more than 21%, the alveolar arterial gradient becomes less accurate to measure the efficiency of gas exchange. So what we can try in these situations where a high FiO2 is used, rather than looking at the AA gradient, we should be looking at PaO2 FiO2 ratio. So PaO2 is 75 to 100 millimeters of mercury, and the FiO2 normally that we deliver is between 21 to 100%. So when we get a ratio between these two, If it is more than 300, it is normal. If it is less than 300, it could be probably acute lung injury. And if it is less than 200, probably we are looking at ARDS. So it may be unreliable, particularly in case of large shunt or low FiO2. So what do we do? So next step is arterial alveolar ratio. So the peculiarity of this particular parameter is relatively unaffected by FiO2. The normal ratio is 0.74 to 0.77 at room air, that is 21% FiO2, and at 100% it is 0.8 to 0.82. When it is decreased, if it is less than 0.6, probably it is a shunt or ventilation perfusion mismatch. If it is less than 0.35, then there is a weaning failure. And if it is less than 0.15, there is a refractory hypoxemia. So this is what all about the ABG interpretation. We remain focused because we have to cover both ABG and PFT. We remain focused only on the interpretation part, and we try to understand that if the ABG is given in exam, how we look at the ABG, what are the methods of validation, and how we interpret it in with the simple steps of looking at pH, looking at partial pressure of carbon dioxide, looking at the bicarbonate level, differentiate between the metabolic and respiratory, then identify whether it is acute or chronic in terms of respiratory pathology, and then we try to understand whether there is any compensation. We look to the anion gap, and we also understood the basics of oxygenation and gas exchange and tried how these values can be used in patients who are hypoxic. In addition to this, the questions that can be asked during discussion on ABG will be about the buffer system, how the sample is collected, what are the methods of heparinization, wet and dry heparinization, how the Allen test is performed, what is positive and negative Allen test, what is strong ion difference, SID, and what are the methods of ABG interpretation. So with this now, we move on to pulmonary function test interpretation. As we all know that there are multiple functions that a lung performs, but when we say pulmonary function test, we are very specific about the mechanical function of the lungs. So PFT will not help in deriving any definitive diagnosis, but definitely it will help us in diagnosing the type of pathology, type of lung disease, whether it is obstructive or restrictive, and it will also help us in grading the severity of the lung disease. So PFT can be divided into three gross categories. The first is bedside testing. Then second is spirometry. So in spirometry, we can have static parameters and dynamic parameters. And then we will be, the third type will be flow volume loops. So these are the different types of PFTs grossly which can be performed. So in bedside PFTs, what we do is we go for detailed history taking and examination. X-ray test again comes in bedside pulmonary function test, a gross test we can say, tracheal auscultation, breath holding time, and cup test. Along with this, what we can perform is match blowing test, Devo nose whistle, handheld spirometer, which will give us idea about vital capacity and peak expiratory flow. Finger pulse oximetry can now be included in the bedside PFT, and 6-minute walk test again can now be considered as a bedside PFT. So these are very basic tests, and as a student, you all should be knowing about all these things. But in exam, what we will be getting in our hand will be the spirometry derived parameters. So coming to the spirometry, static spirometry. So we know that we all are aware about this since our first year in MBBS, and what we derive from this is 4 volumes, that is tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume, and 4 capacities, that is vital capacity, inspiratory capacity, functional residual capacity, and total lung capacity. So when we are discussing pulmonary function test, out of these 8 parameters, what becomes more important to us is vital capacity, functional residual capacity, and total lung capacity. Moving to dynamic flowmetry, this is the graph that we see once the spirometry is performed, on which we can derive 3 values. One is force expiratory volume 1, FEV1, then force vital capacity, FVC, and peak expiratory flow, that is PF. And from this, we can also derive the ratio between FEV1 and FVC. Coming to the flow volume loop, this is how the flow volume loop will be derived after computerized spirometry is performed, and we collect many essential parameters from this, which includes peak expiratory flow, mean expiratory flow at 25%, 50%, 75%, FEV1, that is force expiratory volume in 1 second, inspiratory reserve volume, tidal volume, expiratory reserve volume, inspiratory reserve capacity, vital capacity, and residual volume. So these are the different parameters that we collect, and this is how a standard flow volume loop diagram would look like. Now, in exam, when PFT is given for discussion, either we get a report, what we see on the left side of the screen, where we have all the parameters enumerated and we get their values. So when we get the values, what is the predicted value, and then we get the description of what is the measured and what is the percentage of the predicted value. And if there is an obstruction, then there will be bronchodilated post bronchodilation parameters, which will be present in the same report. Or we get a report which we see on the right side of the screen, where we will be getting the values again in the same format. Along with that, we'll be getting a graphical presentation. So when we are looking at these values, so first let us understand how the FEV1 and FVC graph will look. So what we are seeing in as a green line is a normal curve. So that is where the force expiratory volume that can be seen at 1 second, and then the graph continues and remains in a plateau. So this is how a normal graph will look. But in blue line, which presents the obstruction, what we see is the force expiratory volume is not achieved to that level, because obviously there is an obstruction, and the FVC is achieved slowly, progressively. So this is a classical presentation of obstruction in airway. And what we see in an orange line is a restrictive pattern where the FEV1 is not reached. However, the FVC remains at a plateau. However, the same volume is not received or achieved because of the restrictive pathology. Coming to the flow volume loop, how it looks in obstruction. So what we see in green is a normal loop, and what we see to the right of the screen in pink is pink and blue, both are obstructive pathology. What we see in pink is typical acute asthma, where the peak expiratory flow is reduced and volume is also reduced. And what we see in blue, there is a similar pattern. However, if you could compare the pink and the blue image, what you see is a characteristic scooped out curve. So that is classical of emphysema. Coming to the restrictive diseases and its appearance in the flow volume loop. So again, the green color is normal, and we have 3 patterns of restrictive diseases. The yellow one is related to the obesity. So PEF and the volume is not greatly affected. However, in orange, which is related to the muscle weakness, the peak expiratory flow is reduced, and we can see there is affection of the total volume. And the gray one is a classical restrictive lung disease, or interstitial lung disease we can call, which is secondary to the fibrosis. So this is the classical presentation. So these kind of diagrammatic graphs can also be given in exam, and students are asked to identify the pathology. So just to make the diagnosis simplifying, what we need is the 3 parameters to begin with: FEV1 FVC ratio, FVC, and total lung capacity. If FEV1 FVC ratio, FVC, and total lung capacity are normal, we are looking at a normal pulmonary function test. If FEV1 FVC is reduced, and FVC is also reduced, then probably we are looking at obstructive pathology. In this case, total lung capacity either could be normal or low normal. When we get the obstructive pathology, what we should be looking at is the diffusion lung capacity, in which if it is normal, probably we are looking at asthma or chronic bronchitis. But if lung diffusion is reduced, then it is classical of emphysema. Now coming to the blue table where FEV1, FVC is normal. However, FVC and total lung capacity are decreased. So we are looking at restrictive pathology. So when we look at the restrictive pathology and if we have the diffusion capacity available, if it is normal, probably then it is related to the either chest wall pathology or neuromuscular disorders. And if it is decreased, so in restrictive pathology with decreased lung diffusion, it is classical of interstitial lung disease or pneumonitis. Coming to the gray table where the FEV1 and FVC is reduced, along with FVC and total lung capacity is also reduced, we are looking at a mixed disorder. And coming to the yellow table, where the FEV1 FVC ratio is normal, FVC is normal, total lung capacity is also normal. However, our patient is hypoxic. So if you perform lung capacity, which obviously doesn't happen in these cases, but theoretically, if it is decreased, then it will be indicative of pulmonary vascular disorder. So this is how we can simplify pulmonary function test interpretation in exam. So once we diagnose, we can have different questions which may be related to how the diffusion capacity of the lung, what is the technique, what is the gas used, and how it is graded, how the severity of the obstruction is calculated, and what is GOLD 2020 criteria. When we diagnose one particular pathology, obstructive or restrictive, we can have questions like how to optimize the given patient, what will be the intraoperative management strategy, and what will be the choice of anesthesia, looking at the PFT report, and postoperative issues can also be discussed. So in short, this is actually a very vast topic. Both ABG and PFT each can have 1 hour lecture, but I tried to concise it and try to keep it more focused on how to interpret and what to expect in exams. So I thank you from the bottom of lungs, I can say here, because we talked about ABG and pulmonary function test. And thank again everyone for patient listening.
Dr. Vikas, you can stop sharing.
Hello. Okay, thank you so much, sir. It's the simplest way to teach ABC analysis approach and PFT interpretation. It will be really helpful for theoretical as well as our practical exams for the PG students. Thank you so much, sir.
Thank you.
Hello, everyone. Hello, everyone. I'm announcing a very important note. Due to the technical issues, we are postponing Dr. Divans's lecture on upper respiratory block at 7:15 p.m. onwards. And it is sincere request to all respectable speakers kindly available to us prior to your session. I would like to thank to the Sundaram sir. Thank you so much, sir. You are here and you given us valuable time to us. Now moving to next topic on a diabetes mellitus with DKA for food ulcer debridement. Our speaker is Dr. A.L. Meenakshi Sundaram sir. He is a director of medical education, officer on special duty Tamil Nadu, as well as he won so many awards with him. He had a best teacher awardee by the Tamil Nadu MGR Medical University. He was the vice president of IS National in 2016, and he's a best doctor awardee by Tamil Nadu government, and lot of qualities available with sir. Now over to you, sir. Just guide us on diabetes.
Thank you. At the outset,
Meenakshi doesn't need any introduction. Any introduction less to Dr. Meenakshi Sundar. He is Meenakshi. Anybody will know that.
Actually,
Actually.
very true.
He is the director of medical education, a new thing which we had to him from last few days. Otherwise, he is Meenakshi Sundar. Everyone knows.
Sir,
Welcome.
Venkatgiri sir. Venkatgiri sir, Dr. Meenakshi Sundaram doesn't need any introduction. नाम ही काफी है. नाम ही काफी है उनका.
I
Thank you so
just say
much.
he is Meenakshi Sundaram. He is ALM. That's enough.
Yes, yes, absolutely. Very true. Very true, sir. Thank you so
Sachin is
much.
new to
Thank you,
him.
sir.
Sachin is new to him.
That is the only thing to be added. He is the TMB Tamil Nadu now. That is a new thing. Other things are same. He is our Meenakshi.
thank you very much,
Yes.
National President and Dr. Maya and her team, Pimpri Chinchwad. Really, I am happy because this is the first lecture I am delivering after my promotion as a DME, which is my long pending dream and demand, which I got only on September 9th. And as Dr. Venkatgiri sir pointed out, this is the addition. I thank because Maharashtra is a home away from home for me. So coming to the topic proper.
Meenakshi sir, one correction, not Venkatgiri sir. I am Venkatgiri only for you. Don't tell Venkatgiri sir. Huh? I hear every word you say that.
Anyway, I have to now see diabetes mellitus. It is very difficult to deal. That too, they have given a specific topic as a PG question. Diabetic ketoacidosis in anesthesia. Within 30 minutes, I have to cover. But how I have devised for the benefit of postgraduates, see, randomly it will come as a essay question model as well as the Viva host model. So the postgraduate should clearly listen. I will give them the point of view from the theory part also, as well as from practical clinical case also. So this is just a refreshment. The diabetes is two types, type 1 and type 2. Mainly type 2 insulin dependent diabetes, type 1 IDDM patients are prone for developing a DKA. So type 2 patients, the overweight patients are prone for this. Even type 2 patients can develop diabetic ketoacidosis. That we have to keep in mind. So now coming to the point, if the patient is suffering from diabetes or if the patient is suffering from diabetic ketoacidosis, the patient is having increased risk because of multi-organ dysfunction, mainly the coronaries, kidney, peripheral neuropathy, autonomic neuropathy, and delayed gastric emptying also. So tuberculosis and diabetic can produce multi-organ dysfunction. This we should know, because with this only we are going to evaluate the patient. So diabetes is considered as a coronary equivalent. These people are prone for developing silent myocardial infarction because of autonomic neuropathy, and heart failure is also common in these patients. So we have to keep this also in mind. Again, as the glucose control is not proper, as there is a hyperglycemia, it increases the chances of infection, and it increases the systolic and diastolic dysfunction because of coronary artery disease. And the patient is prone for the stiff joint syndrome. Because of this stiff joint syndrome, which we say detect by prayer sign, there may be a difficulty in intubation for these patients. That is applicable for diabetic ketoacidosis also. So the anti-diabetic agents, there may be many anti-diabetic agents, like oral hypoglycemics, insulin, then alpha glucosidase inhibitors, peptide analog, amylin analog. These are all for theory part I am saying. But now we are going to concentrate on diabetic ketoacidosis. So drugs may be many for diabetes, but now we are going to talk only about insulin, which is vital in diabetic ketoacidosis. Even in insulin, there are so many insulins available, like rapid acting, intermediate acting, short acting, long acting. So many insulins are available, but don't worry. There may be the onset of action. Everything will be given in a graph for variety of insulin. But today, Only regular insulin we are going to use as it is a case of diabetic ketoacidosis. Okay, now if the patient is subjected to general anesthesia in this, because any type of anesthesia, the postgraduates can easily write in examination, whatever may be the case. One general anesthesia is possible, one regional anesthesia is possible, nerve block is possible, and a TIVA, that is IV anesthesia, is possible. So they have to think in terms of these four, and they have to write the pros and cons. So if you are subjecting this patient for general anesthesia, it is a surgery is a relative insulin hyposecretion and insulin resistance. The stress hormones will be more, and in general anesthesia, the stress response will be more. So there will be acute hyperglycemia, which produces dehydration. That leads to impaired wound healing. And again, as I said, there will be increased rate of infection. So there is a worsening ischemia part. If the ischemia affects central nervous system, or because of hyperviscosity, if there is a thrombogenesis, it creates more of a problem in general anesthesia. In nutshell, whatever I have mentioned earlier is a catabolic effect of surgery, which is aggravated by general anesthesia, but we want to have anabolic effects, that is management of anesthesia in diabetes as well as in diabetic ketoacidosis. So if the glucose level is more, it produces non-enzymatic glycosylation reactions. So abnormal proteins are synthesized, which weakens the endothelial junction. That is the reason why the patient is having a stiff joint syndrome, which is identified by a Prayer sign. Then, because of macroglobulin, blood viscosity is increased. That leads to thromboembolism. Then, the worst part of diabetes mellitus is autonomic neuropathy. This we have to identify both peripheral neuropathy and autonomic neuropathy. Peripheral neuropathy is important for central neuraxis blockade, for medico-legal reasons also, because we may be blamed that because of spinal anesthesia, the patient has developed a numbness in the feet. But that may be due to peripheral neuropathy, which should be documented by your Ramberg sign or whatever may be the modality. So this autonomic neuropathy, if the patients are suffering, there is an exaggerated pressure response to the tracheal intubation. So general anesthesia, you have to write that. So again, if it is a central neuraxis blockade, even then it produces intraoperative hypothermia. That is a problem, and because of this, there may be unawareness of hypoglycemia. We have to keep in mind. So in the autonomic neuropathy, the action of atropine will be questionable. Same way, the action of beta blockers will be questionable. It is unpredictable. So we have to note that before administering anesthesia, both vagal control will be deranged, cardiac accelerator control will be deranged. So the entirely it will be erratic behavior will be there. We have to be prepared for anything. And respiratory reflexes, even for hypoxia and hypercarbia, may be impaired in autonomic neuropathy. Again, because of autonomic neuropathy, sweating will not be there, because these are all to be elicited in the history. Impotence, erectile dysfunction, everything will be there. But in preoperative evaluation, we have to check postural hypotension and resting tachycardia, which may indicate autonomic neuropathy. And the autonomic neuropathy itself may be a short notes for the postgraduates. So I have given the nocturnal diarrhea, dense peripheral neuropathy, impaired respiratory responses, everything was added because you have to answer in theory part also. Then sudden cardiac arrest is possible in autonomic neuropathy because of interference with the respiration. Interference with the respiration can happen due to the commonest infection in diabetics, pneumonia, then our anesthetic agents, mainly inhalation agents, then sedatives. So with this in mind, if you are going for general anesthesia, the anesthetic management in the preoperative evaluation, blood glucose level only is not important, even in ketoacidosis also. We have to assess the end organ damage. Coming to the DKA proper, diabetic ketoacidosis is an acute state of severe uncontrolled diabetes associated with the production of ketones and acidosis. This flow chart I am giving only to say, see, this insulin deficiency affects glucose metabolism, it affects protein metabolism, it affects lipid metabolism. So diabetes affects all the three. We have to keep in mind. Then the PGs can elaborate what is happening in the particular metabolism. In glucose metabolism, hyperglycemia happens. In protein metabolism, it produces catabolism actually. But we want the anabolic effects. So in catabolism, there is increased amino acid. So increased nitrogen loss. Again, it stimulates gluconeogenesis, producing hyperglycemia. But in lipolysis, it increases glycerol, which also increases glucose level. And these free fatty acids produce ketones. So in diabetic ketoacidosis, direct responsibility is lipid metabolism. But in addition to that, both carbohydrate and protein metabolism is affected. So we have to keep all the three. So what are all the precipitating factors for this diabetic ketoacidosis? Because we have to treat that. So it could be infection. That is the reason why the wound debridement, as they have mentioned, that the infection would have produced ketoacidosis. So by solving the infection, the patient may recover from ketoacidosis. Again, it may be due to infarction. It may be due to lack of insulin. It may be due to indiscriminate use of drugs. Then pregnancy. Then any injury. Injury, indirectly, the stress response is more. So in my way of telling, for the postgraduate, you remember I. Actually, I should not be there. That ego should not be there. But in diabetic ketoacidosis, I is the precipitating factors. Infection, infarction, insulin problem, indiscriminate use of drugs, injuries, and pregnancy. You can have inside the uterus, there is a baby. That will also come as I. And again, as a routine. Idiopathic, that is also a I. That is unidentified factor may predispose to DKA. We used to say idiopathic means it is idiocy on the part of the doctor and pathetic on the part of the patient. So unidentified, you add. So in this, the anesthetic management, the glucose control is maintained by one, the nature of surgery, whether the patient is pregnant or not, what is the CNS insult, the bias of the primary care physician, and the type of diabetes. So what is the preoperative evaluation in this patient? DKA, assess end organ damage and glycemic control. History, physical examination, I need not elaborate on that. Assess the asymptomatic coronary artery disease, that is vital. Then these are all the points postgraduates should write in the examination. Document pulses, because sometimes some pulse may not be palpable because of the accelerated atherosclerosis. It has to be marked. Then skin breaches, for medical legal purposes also, it should be mentioned. As I said, the sensory examination. Then orthostatic vital signs, autonomic dysfunction. These are all the things to be marked in the case sheet to protect us also. In addition, that ECG, urea creatinine, electrolyte glucose, and HbA1c should be monitored. Then assess the concurrent medications, end organ damage, autonomic neuropathy. If the patient is suffering from autonomic neuropathy, he should be labeled as a full stomach. We have to keep in mind. So the pre-medication, you can go for ranitidine metoclopramide. Aspirin prophylaxis is allowed. No problem of bleeding with the aspirin, but don't use anticholinergics. So the investigations, as I said, mainly the ECG, the electrolytes, ABG. ABG, if needed only for this patient. If it is a young age, we need not go for it specifically. But if ketosis is not responsible, you have to go for ABG also. So in exam, as it is mentioned as diabetic ketoacidosis, you write, I will go for arterial blood gas as a screening test. Then in the whatever may be your anesthesia selection, your aim will be avoid hypoglycemia and hyperglycemia. So you have to necessarily do frequent laboratory analysis, and you have to go for gradual reduction in blood glucose levels, or else cerebral edema will occur. You cannot give 100 units of insulin as IV shot to bring down the glucose level. Then we have to use only rapid acting insulin, no long acting insulin in DKA. So in DKA, the recovery may be very slow, but you have to proceed with the surgery. You cannot say that I will not operate on the patient, because at the maximum you can take only 4 hours at the maximum. Within 2 hours you have to intervene. because it may produce cerebral edema, arrhythmia, infarction. The patient may even die because of that. So in emergency, don't delay. Immediately you go for a insulin bolus, 0.1 unit per kg, followed by an infusion, same, that 0.1 is per hour of the initial prescription. Then, as I said, definitely you have to monitor the serum glucose level frequently. And in addition to that, the electrolyte monitoring is also mandatory, because even the phosphate deficiency can produce problem with the patient. And if it is a DKA, you just have this in mind. First, replace fluids. That is ultimately important. Fluid, because lot of fluid loss will be there. Severe dehydration will be there. So replace fluid, then go for insulin replacement, then potassium and phosphate. Bicarbonate replacement, we have to be very careful and manage the precipitating factors. So in emergency, if the blood glucose level decreases less than 250, it should be substituted with dextrose fluid. Before that, it should be only normal saline. And insulin to be continued till acidosis resolves. So don't delay surgery because of DKA. Within 2 hours, you can correct the intravascular volume deficit. So you correct that. So insulin routinely, if you are not going to give as 0.1 unit per kg as bolus, you give 10 units regular insulin as bolus. Then every time, every hour, you have to check blood sugar. So if the measured blood glucose is divided by 150, that would be the basal infusion per hour. So you can have even a syringe infusion. If the patient is receiving steroids or overweight, divided by 100, because they require more insulin. Again, however much we train, frequent monitoring is important. So you monitor the blood glucose at least every hour, and don't keep on pushing so much of insulin, because insulin binding sites are limited. So the blood glucose level will be slowly dropping. So you have to wait. So you can proceed with the resuscitation and the anesthetic management simultaneously. So the IV fluid, 3 to 5 liters may required. Then you have to remember pseudo hyponatremia. That's what I want to say. Because of this hyperglycemia, the pseudo hyponatremia will be there. So they may be looking like a real male, but it may be dolls in the showroom. We have to remember that. So sodium decreases every 1.6 milliequivalent per liter for every 100 milligram of increase in glucose. So if there is a hyponatremia, rule out whether it is a true hyponatremia or pseudo hyponatremia. So in acidosis, you have to check ABG. I said even in the preoperative evaluation, you have to do that. And in diabetic ketoacidosis, it is acidosis with increased anion gap. Dr. Vikas Karne right now discussed. So the persistent ketoacidosis with bicarbonate less than 20 indicates continuous need for glucose. So till glucose is 250, non-glucose fluid. After the blood sugar reaches 250, you have to give glucose with the insulin and the potassium. Bicarbonate. Please remember, there is no bicarbonate role for in diabetic ketoacidosis. But even then, as a completion sake, you have to write it in the exam. So there are 6 indications. If the pH is less than 7, because at the level of pH 7, myocardial depression will occur. So you have to rapidly go for the correction. And if the bicarbonate is less than 5, you can correct. Then immediate cardiovascular collapse or coma, hyperkalemia, and coexisting lactic acidosis. Even if you use bicarbonate, you have to correct only 25 to 50% and don't go for full correction. The electrolyte disturbance, as I said, potassium, phosphorus, magnesium, everything has to be taken care of. So once that resuscitation process is going on, we have to go for anesthetizing the patient. So as I said, any anesthesia, it could be general anesthesia or central neuraxial blockade or peripheral nerve blocks or IV anesthesia. But in regional anesthesia, the local anesthetic requirements are lower. At the same time, the nerve injury chances are increased in diabetes mellitus. So you don't go for eliciting paresthesia. It may be there or may not be there. So always ultrasound guided nerve block is better in diabetic patients. Don't add any vasoconstrictors just to prolong the action of local anesthetic, because the chances of ischemic nerve injury will be more. Then remember autonomic neuropathy and peripheral neuropathy. And if you are going for central neuroaxis blockade, remember the hemodynamic problems. So now come to anesthesia proper. As I said, GA don't venture. For in this case, in exam, if it is asked oral, you have to say general anesthesia, I will not venture because it is in the foot. That produces severe catabolic effects. In central neuroaxial blockade, you can go for spinal because it is easy for everyone. In spinal, you can go for saddle block, that is blocking only the sacral segments, because the hemodynamic affection will be minimal in that. Then you can go for epidural. Caudal is also a form of epidural. These are all the possibilities you can use in anesthetic management. But the safest way for this particular patient, in diabetic ketoacidosis, is nerve block, mainly ultrasound guided nerve block. So this nerve block, you can go for femoral and sciatic nerve block if you are well versed with that. But better that the saphenous nerve block at the level of adductor canal, so that more proximal block is beneficial with the sciatic nerve block will be good for this ankle surgery. Do that with ultrasound guided as a nerve block. Second thing is possible is ankle block, which we were practiced earlier. Now in the present trend, if the same question is asked in the examination, you have to say it is a saphenous nerve and a sciatic nerve block for the foot anyway, because the medial surface is covered by saphenous nerve. So that should be the first answer, femoral nerve and a sciatic nerve. Second comes your ankle block, because ankle block is a very painful block. That itself is very painful, and you have to anesthetize 5 nerves: posterior tibial, superficial, peroneal, deep peroneal, sural, and saphenous. So you have to keep it in mind. In the postoperative period, again, the net effects of neuroendocrine response because of the surgery, it again produces increased glucose, lipolysis, protein catabolism. So if you are going for a peripheral nerve block, you can offer postoperative pain relief also. So you have to think that way also. So in postoperative care, you maintain in high dependency unit, always check glucose level and maintain it at 50 milligram, and change to preoperative schedule after oral intake. So continuous check in the postoperative period is also mandatory. Pain relief is also mandatory. So remember, diabetic ketoacidosis is a thrombotic state. It can precipitate even stroke. We will be thinking only in terms of cardiac, but as it is a thrombotic state, it can produce a stroke. Same way, the stroke can also precipitate diabetic ketoacidosis. So we have to act swiftly and with wisdom. As I said, if it is anesthetic management in orals, you say first nerve block, then the central neuraxial block, then GA, you are not supposed to say. For completion sake, you have to write in a theory. GA will be produce lot of problems in these patients. This is a take-home message. So I thank Dr. Maya and the powerful women of Pimpri Chinchwad SAPC for this wonderful opportunity. Thank you.
Thank you, Dr. Meenakshi Sundaram. And it was really wonderful presentation, elaborate yet to the point. Okay, so thank you very much. And I would like to congratulate you for the feat you are taking into the education field, apart from into, directly medical academics. It's really commendable and proud moment for each one of us. So as far as questions are concerned, as of now, I don't see any questions.
No question.
Okay. Okay. Can we proceed with the next?
Thank you, madam. Thank you all.
Thank you so much, sir.
Thank you, sir.
So I would like to proceed with our next speaker. I hope my screen is visible.
Yes.
Yes, ma'am.
Just a minute.
Just give me a moment. There was some different screen. Okay. So Dr. Anju Grewal, she's a professor and head Department of Anesthesiology, Dayanand Medical College and Hospital at Ludhiana. She's Vice President of Research Society of Anesthesiology Clinical Pharmacology, National Secretary for Association of Obstetric Anesthesiologists India. She's Associate Editor of International Journal of Regional Anesthesia and Coordinator of DMCH AHA Training Site, AHA, BLS and ACLS courses. She has been the former chief editor for Journal of Anesthesiologists Clinical Pharmacology and former scientific chairperson, National ESECON 2016, Ludhiana. So welcome, ma'am. And that was, really breathtaking introduction. So I would like to welcome ma'am for the topic on mitral stenosis with MVR done for laparoscopic ovarian cystectomy. So I would like to hand it over to ma'am. I'll stop sharing the screen.
Thank you so much. Thank you so much for such a generous introduction. Indeed, congratulations to the entire team. I've been hearing rave reviews of a wonderful program that you have all done in person. Am I audible to all of you?
Thank you, ma'am. You are audible and we can see your screen as well.
Thank you so much. So it'll be a brief presentation for the students, right? My whole purpose is to just highlight the major issues that are concerning this topic. So what we are looking at is a case of mitral stenosis who has had a mitral valve replacement and now is posted for a laparoscopic ovarian cystectomy, right? I bring you greetings from Dayanand Medical College and Hospital at Ludhiana, the place where I work. So we'll talk about what are the anesthetic issues around prosthetic valves, in particular about the mitral valves. What are the anticoagulation and bridging issues when we take these patients for surgery? We look at whether there is a need for giving them an infective endocarditis prophylaxis, and then what are the anesthetic goals while we do this particular scenario, okay? So if you look at the anesthetic considerations, the first and the foremost thing that should come to the mind of an anesthesiologist as you encounter this patient, or if this patient is there for your case presentation in the exam, the first thing is that what is the kind of prosthetic mitral valve up there, when it is there, so what is the type and what is the age, the duration. So we'll talk about prosthetic mitral valves. They're mainly metallic or mechanical, I would say, not metallic, and then bioprosthetic. And of course, we need to look at what is the current valvular function after the mitral valve replacement has been done for this patient. Are there any residual effects of the mitral stenosis coming in? And of course, the functional status of the patient, which will help us to guide what anesthetic regimen we want to give to this patient. Now we're coming one by one to each, looking at what is the type and age. Why is it relevant to us? Because we all know there are two types, mechanical as well as bioprosthetic. Now, mechanical are good in the sense that they are viable for a very long period of time. So they're usually given to patients who have a long life expectancy. But the downside is that they need long-term anticoagulation, especially with, just a minute, I'll just hide my, they will need a long-time anticoagulation, especially, with the vitamin K antagonist, warfarin, and of course, aspirin, if there are more risk factors involved up there. Okay. And though they have a good viability, the anticoagulation needed is pretty high. On the other hand, there are bioprosthetic mitral valves, which, need anticoagulation with the help of your warfarin for the initial 3 to 6 months period, and then they are followed by a lifelong aspirin. So they are like safe for us in the perioperative period. But the issues are that they are prone to degeneration. So they degenerate in 5 to 10 years, and there is a reappearance of symptoms coming up. So most of the times, these are offered to either individuals who do not have, had a lot of comorbidities, and we do not expecting a long lifetime expectancy for this patient, so they're given bioprosthetic mitral valves. And in younger population to childbearing women who want to have pregnancy, because we have to remember that warfarin does have a lot amount of teratogenic effects on the growing fetus, especially in the first trimester of pregnancy. So this is how, we need to understand and why is it important to us. And another importance is, depending upon the type, we will be faced with valve dysfunction if it is a bioprosthetic, or even if it is a mechanical one, which encompasses a lot of anticoagulation. So there will be risk of bleeding versus thromboembolism. So thromboembolism, if the anticoagulation is inappropriate or is low dose or is not appropriately dosed, so that can come in. Also, a lot of thrombus generation around even a mechanical valve can lead to valve dysfunction. So these are the issues that are the major issues, I would say, when we look at these kind of patients. So when they come to us for preoperative evaluation, one, we looked at the type and the duration of the valve that we are looking at, and then which has been replaced for mitral stenosis. And second, now we need to look at whatever is there is how good is that valve functioning, right? The best indicator to do it is to use a transthoracic echocardiography and compare this current echocardiography report with the index endocardiography report. Now, what do I mean by index echocardiography report? Is a report that was done in the immediate post-operative period when the valve was replaced, okay? And so that will tell us how well or how degeneration the valve has undergone during that period of time. The residual effects, the next we need to look at the residual effects of underlying mitral stenosis, if any. We also need to look at the current functional status of the patient and in respect to the period after valve replacement surgery, right? So if you look at the, I've tried to mix a few guidelines also in together, and there are a lot of newer guidelines in 2021 and 2022 coming in. So if you look at the recommendations up there, what they basically say that in patients with surgical or transcatheter prosthetic valve, the transcatheter prosthetic valves are usually reserved mainly for aortic valve. There are very few, places where they do a transcatheter mitral valve replacement. The initial post-procedural echocardiography is recommended for evaluation of valve hemodynamics and ventricular function, right? So initially it is important immediately after the surgery. Again, it is important to have it if there is a change in the clinical symptoms which suggests there is a valve dysfunction coming in. So therefore, history taking is extremely important for this patient. Another indication is in patients where there has been a prosthetic valve replacement, that clinical symptoms or signs that suggest prosthetic valve dysfunction, you might need additional imaging with echocardiography, say a gated cardiac CT or even an MRI might be indicated, because at times it might not show, the transthoracic echocardiography might not show a dysfunction, but there could be a dysfunction coming in because the symptoms are suggesting so. And of course, you need to reevaluate if you're towards the end period of those valves, especially bioprosthetic valves, and the patient is coming to you in the 5 to 10 year period for an ovarian cystectomy, you really need to do a echocardiography. So echocardiography basically stays as the primary imaging modality for, not only assessing this valve function and the immediate post-operative period. When I say post-operative period, is the post-operative period following the valve replacement and not in the for this non-cardiac surgery, right? And it's very important that all throughout, whenever they got their mitral valve replaced, all throughout till now, when they have come to you for a non-cardiac surgery, there has to be, attention to dental care, endocarditis prophylaxis, and anticoagulation. Have they been taken in very well? And we need to evaluate, are there any underlying complications or not? Now, how do we go about doing that? Is, of course, we all need to remember thorough history taking is extremely, extremely important, right? So talking to your patients about breathlessness, dyspnea, current functional status. A very important point that I want to mention here to students is we just keep asking them questions as per our tick mark on our PAC forms. But what we really need to talk to our patients is what are they doing exactly? If the person just sits at home and walks from room to kitchen and kitchen to washroom, that the functional status of that patient is pretty low as compared to a person who tells you that he walks down to his clinic or to his shop, which is say a kilometer or a 2 kilometer away. So you need to understand what the basic baseline activity of this patient is, and does this patient, if ever, increases his or her activity level, are there symptoms of dyspnea coming in? Of course, it's important to know history of palpitations that might indicate an underlying atrial fibrillation up there. Bruising after trivial trauma is very important, especially when they are on anticoagulation. History of anasarca, jaundice. Jaundice would actually tell you that there is a paravalvular leak, that the valve has now started to dysfunction. And of course, history of previous hospitalization for cardiorespiratory symptoms, signifying that there were episodes of acute heart failure, and the medications that this patient would be on. Right? And this thorough history taking needs to be followed by a detailed general physical and systemic examination. And a purpose here is to elicit the signs of atrial fibrillation, heart failure, pulmonary, arterial hypertension or pulmonary edema, as the case may be. And also, very importantly, to do a neurological exam to look for any embolic or hemorrhagic stroke coming up there, right? But extremely important, look for pallor, look for icterus, for paravalvular leak might lead to some amount of indirect bilirubin getting increased, and the character of the pulse. So these are very important things that we all need to do. Pick up your stethoscope, look, auscultate for crepitations, for unusual murmurs, and do all of these together, right? Just to get you through the NYHA classification, I know all of you know it, but we really need to document it. So we know that the patient who has no functional limitation on activity falls into class 1, and then as there is a limitation to the functional limitation to activities, the grade keeps on increasing, right? So just to remember it at a glance, if the patient complains to you of symptoms at rest, he or she categorically falls into, now this is a female patient, so it categorically falls into class 4, right? And if symptoms on activity are none, then the patient is of course in class 1. Whereas if they are mildly present, the patient falls into 2 and 3. And if they are quite bad, then the patient falls into 4. So that would be orthopnea coming in this particular group of patients. So NYHA classification is extremely important in these patients. So tell you what is the degree of functional status, what is the degree of dyspnea, and give you a lot of indications on the valve function as well. Now, having had a detailed history and an examination, you need to order investigations. So what are the investigations that you need to order, and why do you need to order is something that's very important, right? So if you're ordering for a hemogram, we are looking at, of course, signs of anemia. Sometimes there would be anemia because of the paravalvular leak that is occurring, can cause a lot of hemolysis up there around the valve. And so hence that is important. Reticulocyte count might be increased. And patients who are on say, heparin, unfractionated heparin or low molecular weight heparin for more than 4 days, there can be an heparin-induced thrombocytopenia. So a platelet count should always be looked at in a CBC. LFTs, as I said, they could be indicators of subclinical hemolysis in the form of increased LDH, increased indirect bilirubin or AST levels. If we need to also look at the adequacy of anticoagulation, and therefore PTINR and of course APTT if the patient is an unfractionated heparins is extremely important. Serum electrolytes are usually indicated because these patients might be on ACE inhibitors or ARB inhibitors, which can lead to hyperkalemia. RFTs, of course, as a baseline measure, and also we will need to know what the renal function is while we are doing bridging with various agents, right? Your anticoagulants. The dosing would be altered with that. And of course, we look at chest X-ray and the hallmark, the main, I would say, one of the biggest investigations that should always be ordered and is a resting transthoracic echocardiography. Remember, structural changes are best delineated by echocardiography. So basically, with the transthoracic echocardiography, what we are trying to look at is the function of the valve. So when you order an echo to your cardiologist, please do write what you want to know from the patient, that cardiologist. So we're trying to elicit the movement of the leaflets, the pressure gradient across the implanted prosthetic valve. We are determining the effective valvular area. Remember, these valves can get into stenosis also. And of course, regurgitant also both can occur. Then the paravalvular leak, and very importantly, to look at vegetations, right? In addition, we need to look at global and regional right and left ventricular systolic function and size. Remember, mitral stenosis will not only cause RV dysfunction and pulmonary arterial hypertension, but at times can also lead to left ventricular dysfunction as well, right? Needless to say, look at the atrial size, the enlarged left atrium, look at the thrombus if they are present or not. These are very important. And sometimes the posterior aspects are not visible well, especially if you're looking at, the aortic valves. And we are, of course, talking about mitral valves. In that case, we might need to add on transesophageal echocardiography, which will give you a superior imaging, especially on the to look at LA on the if you're looking at LA side of the mitral valve processes or the posterior aspect of aortic valve. So these are a few things that you must be aware of what to look at in an echocardiography. So having had your investigations, having risk stratified your patients, taken a proper informed consent, we now need to move forward to plan for anesthesia, right? So while we are planning for anesthesia, it's important to look at the status of anticoagulation. Needless to say, all of these patients would be on anticoagulant, right? Some form of the anticoagulant or not. So we need to look at what is the risk of bleeding versus thrombotic risk in this particular patient. Is the anticoagulation adequate? Are there bleeding risks which have led to some amount of bleeding, or it is inadequate, which has led to some kind of a embolic stroke happening in this patient? Also, we'll have to now prepare for reversal of anticoagulation in the perioperative period if it is needed, and then when to restart and switch back to the oral therapy is also important for us to know. So these are the main hallmark that we are going to plan for, right? So as I said, we need to evaluate the bleeding risk versus a thromboembolism risk. Remember, the thromboembolic risks are always greater than the bleeding risk. You can control the bleeding, right? But and address that issue. But a thromboembolic risk will majority of the times entail an end organ damage, which will be coming in. So therefore, this balance has to be created, one. And two, you need to understand, does my patient need bridging at a period of, in the perioperative period, when we're going to withdraw or stop the anticoagulants during surgery, right? So what are the factors that we consider while we decide whether or not bridging is needed? So first is the type of surgery. What kind of surgery are we looking at? Is minor, or it is a medium kind of a surgery with less risk, minimal or moderate risk of bleeding, or a high risk of bleeding, right? What is the type and location of prosthetic valves? Remember, between an aortic prosthetic and a mitral valve, prosthetic valve, mitral prosthetic valves have higher probability of having thrombus formation because the flow across this valve is lesser as compared to the aortic valve, right? And therefore, very important to look at and find out the risk factors for thromboembolism. So from our history and examination and our investigations, we have tried to delineate whether or not there is presence of atrial fibrillation, a previous history of thromboembolism, a hypercoagulable condition like pregnancy, older generation bulkage, or tilting disc mechanical valves. So knowing your valves are very important, and it's good to have the patients get in their records. Left ventricular systolic dysfunction, which you will get to know if you're going to do a good echocardiography, and of course, dysfunction of more than 2 mechanical valves, right? I forgot to write 2 there. And length at which the anticoagulation will have to be withheld is another indicator, and the risk of bleeding, right? So when you look at the type of surgery, now what we have to know that surgeries with minor bleeding risk, like say cataract, glaucoma procedures, dental procedures where there are extractions or periodontal surgeries, or root canal procedures, endoscopies without biopsy or resections, and superficial surgeries, all of them will entail a minor bleeding risk. This is important to remember, why we will look in the next slide. Then there are surgeries with low bleeding risk, right? With maybe an infrequent or low clinical impact. Say, for example, a cholecystectomy, a hernia repair, a colonic resection, a breast surgery. So our patient of ovarian cystectomy would actually fall into this category. Surgeries with high bleeding risk would be meaning where you're doing an abdominal surgery, say with a liver biopsy or an extensive cancer surgery. You're putting in you're planning neuraxial anesthesia for this patient, neurosurgical or major orthopedic surgeries. So all of these would actually entail a significant bleeding risk in this patient. That means that the clinical impact of the bleeding would be high. For example, if there is a bleeding in the neuraxial component, we know it will lead to a neuraxial hematoma and paraplegia or paraparesis for the patient, right? So that is the clinical impact that we are talking about. So now look at what are the recommendations of anticoagulation stoppages now. How do we actually go about? So if you have a patient who is undergoing minor procedures, as I talked to you, so dental extractions, cataract removal, where the bleeding can easily be controlled, the continuation of your warfarin anticoagulation within the therapeutic and INR, the recommended INR for that patient is recommended. You need not stop your anticoagulation. But if the patient has a bileaflet mechanical aortic valve replacement with no risk factors for thromboembolism, is scheduled to undergo an invasive procedure, then a temporary interruption of warfarin anticoagulation without bridging agents is recommended. And at that point in time, we need to remember that the INR would be subtherapeutic, right? So in nutshell, minor surgery, we do not stop any anticoagulation, okay? And if there is a bileaflet mechanical aortic valve with no risk factors of thromboembolism, we can also have a temporary interruption without bridging coming in. But if there's an emergency surgery coming in for this particular patient who has a mechanical valve prosthesis there, and there is an immediate need for an emergency non-cardiac surgery or an invasive procedure, then we need to reverse this anticoagulation with the help of a 4-factor prothrombin complex concentrate. Very difficult to find in many centers. So the alternative is a fresh frozen plasma that we can give to these patients, right? Of course, under monitoring. Monitoring would means we'll monitor the APTT and PTINR both, right? Patients with bioprosthetic heart valves or annuloplastic rings who are receiving anticoagulation, especially for atrial fibrillation. Now, these are the patients where you need to continue the bridging anticoagulant while you're stopping the oral anticoagulant that this patient might be taking. The patients would most likely would be on, patients who are on bioprosthetic heart valves would usually be on VKAs, that's warfarin, right? So we will try to elicit the score of thromboembolism. We all are aware of the CHADS DS2 VAS score, which comprises of history of congestive heart failure, hypertension, age more than 75 years, which is given a score of 2, diabetes, mellitus, stroke, vascular disease, age 65 to 74, and of course, sex category, that is female. So there are two score 2 for stroke as well as age more than 75. The rest of the scores are 1 and the total score is 9. So if there is a risk, so we'll try to weigh the risk of bleeding versus the thromboembolic risk. And as I told you earlier, thromboembolic risk score is always higher, and therefore bridging anticoagulant is extremely important for that. And coming to our patient who might be having a mechanical mitral valve replaced up there, right? So a bridging anticoagulation therapy in the preoperative time interval when the INR is subtherapeutic is reasonable on an individualized basis. Of course, at all times, we need to have a multidisciplinary consultation with our surgeons to look at the risk of bleeding weighed against the benefits of thromboembolism prevention. So a cardiologist also needs to come into play, okay? Now, this is what the 2020 guidelines, which has been issued in 2021, talking to us about management of valvular heart disease patients looking at. Now, if you look at this entire screen, what we're looking at is a mechanical mat. If you're looking at a mechanical mitral valve, the recommended anticoagulation target with the valve in situ is an INR goal of 3. right? And if they have additional features like atrial fibrillation or previous history of thromboembolism, and aspirin is also added over to that. Now, we need to interrupt this for non-cardiac procedures, surgeries, especially those which entail minor bleeding, which may or may not have a clinical impact, and of course, major bleeding. So you need to do bridging anticoagulation for both of these categories, right? On the other hand, if you have a patient with a bioprosthetic surgical mitral valve replacement, and the patient comes to you for surgery within the 3 to 6 month period, that's the period where this patient will always be on warfarin and anticoagulation with an INR goal of 2.5. So this patient will also need bridging for you, right? And of course, if the patient comes beyond this period, then this patient would usually be on aspirin, which can be continued in the perioperative period. On the other hand, patients who have undergone TAVI might be having two anticoagulants, say a clopidogrel and an aspirin going on together. And therefore, you'll have to now take a judgment call, especially if you are planning a central neuraxial block, right? So just this is the same thing that they have tried to summarize. There's a high risk of bleeding during non-cardiac surgery. If the answer to it is yes, and the answer to a high thrombotic risk is also yes, you have a mechanical valve looking at you and the patient sitting up there in the mitral area, and the patient is on warfarin, this patient will need a bridging therapy. On the other hand, there could be patients who have high risk of thromboembolic phenomena happening. And so if it is an elective surgery, we must first try to address the thromboembolic risk, lessen it down, optimize it, defer the non-cardiac surgery if possible. And only if it is not possible and you need to go ahead and do it, say it's a time-sensitive surgery, say a cancer surgery up there coming in, or there is a spinal canal stenosis up there and that is causing symptoms coming in of deterioration because of spinal canal stenosis, it becomes a time-sensitive surgery. We might need to bridge now the anticoagulants, okay? Now, what are the bridging done with? Usual bridging regimens are with the use of intravenous unfractionated heparin or with the use of subcutaneous low molecular weight heparin, right? And they are usually started 36 to 48 hours before surgery. And in patients where there's a high risk of thromboembolism, you actually need to have a cover of both and keep the target INR there. So, you know, while you are introducing unfractionated heparin, you would still continue with your warfarin till you have reached the target, and then you will withdraw your. So 36 to 48 hours period is the time that you start these anticoagulants as bridging therapy, and you would stop 4 to 6 hours prior if you're using intravenous unfractionated heparin, and a low molecular weight heparin will have to be stopped 12 to 24 hours, depending whether it's a prophylactic or a therapeutic dose that you're giving to the patient. Post-surgery, restarting of your warfarin will be within 48 hours when the risk of bleeding is minimal. So in some cases, in neurosurgical cases, you might have to defer it a little more, but need to continually monitor your patients. But we need to remember that though there are guidelines for newer oral anticoagulants like dabigatran, apixaban, and rivaroxaban, these are usually not recommended in prosthetic mitral valves, right? So these patients usually will not have it. Some, if at all they do have it, we'll have to look at the renal function, and based on that, they would be, you know, dosing as well as indications for when to stop the the newer oral anticoagulant, and no bridging is required for these agents. Okay. So having looked at the aspect of anticoagulation and optimized it and having planned it out, now is the role of do we really administer infective endocarditis prophylaxis to these patients? So IA prophylaxis is now, as we all know, reserved for very specific indications. And the latest guideline that has come in 2021 gives you even indications on how to test whether this patient actually falls into the category of infective endocarditis. So it is reserved mainly for patients who have history of previous infective endocarditis, have prosthetic cardiac valves, so a patient would need one. And of course, they also extended to transcatheter implanted prostheses and homographs. So wherever a prosthetic material is used, either for cardiac valve repair or a congenital heart disease repair, you know, these are the places where a IE prophylaxis would be needed for these patients. And of course, you'll have to tailor your antibiotics depending upon the flora that you're going to look at. But remember, non-pharmacological measures are extremely important. Now, what are those non-pharmacological measures? Dental care, good skin asepsis. So all of these are also utmost importance in preventing infective endocarditis. Now, coming to the mainstays of what is the technique of anesthesia that you would now like to plan. Now, it will all depend again on the nature of your surgery, whether it's emergency or elective, the invasiveness of the surgery. And in our case, we know we are going to introduce pneumoperitoneum and position as additional cardiovascular stressors to these patients. And we'll also look at current cardiac risk factors, including residual valvular lesion. So there might be an element of mitral stenosis lurking in up there or coming back. And of course, the status of anticoagulation, which we have talked in detail right now. Right? And the goals of anesthesia for any of these patients with valvular heart disease, as we all know, is to minimize the myocardial depression and optimize our myocardial oxygen requirements and cardiac output. So we really need to look at a stroke volume, our heart rate, our preloads, and our afterload very well, right? So, and of course, as very well stated, it will depend upon what kind of underlying cardiac lesion we were looking at. Is it still there? And what is the present cardiac status, especially looking at the presence of atrial fibrillation, pulmonary hypertension, and left ventricular dysfunction. So they should be your mainstay. And the one good way to plan is to make a grid, a cardiac grid mantra. Have these 5 factors which play a very important role in your management. Preload, the pulmonary vascular resistance, the heart rate, myocardial, and the rhythm, of course, the sinus rhythm, a myocardial contractility, and the systemic vascular resistance. That's your afterload. Okay. And we also need to understand that while we're looking at this grid, we need to also see how does laparoscopic surgery, which brings in an increase in the intra-abdominal pressure and hypercarbia along with a Trendelenburg position. So this patient would be going head down, right? So with her feet up in the stirrups up there, what would that add to the cardiovascular system? So that, of course, we all know is going to cause an increase in the heart rate, an increase in the preload and the pulmonary vascular resistance. So the right atrial pressures, the pulmonary capillary wedge pressure, all are going to increase, especially during insufflation, and then decrease during desufflation. Remember that as well. The systemic vascular resistance is also going to increase during insufflation and drop down during desufflation. And the cardiac output will decrease not only because of the effects of laparoscopic, the increased IAP, the compression of the inferior aorta and the inferior vena cava, but also because of the anesthetic agents, the type of anesthetic agents that we have all used till now, right? So while we remember that, we need to remember that a stenotic lesion with a prosthetic valve and some residual stenotic issue coming up, along with laparoscopy, is actually, they are all kind of exaggerating the whole scenario for us. So there would be an increase in preload, which means that the transvalvular gradient would be increased, and this would lead to back pressure changes and pulmonary edema, more so because the pulmonary venous pressure is also decreased, the patient is head down, and there is a decrease on cardiac pressure sitting up there. So this all would lead to a propensity to have an early flash pulmonary edema, is something that we can expect. A left ventricular diastolic dysfunction would get exaggerated if it is already pre-existing or if your drugs are not titrated to the effect. Systemic vascular resistance needs to be very carefully monitored because this would drop down, and whenever it drops down would lead to reduced diastolic and coronary pressures, and myocardial ischemia would be coming in. So that is something we really need to be careful about, though we know that the systemic vascular resistance initially might be increased, but can decrease on desufflation. And of course, the hallmark of our management of mitral stenosis, maintaining the patient in normal sinus rhythm. And both laparoscopic and head-on position, all of them are also going to increase your heart rate. So it will lead on to complications like atrial fibrillation, pulmonary edema, as I said, and thrombus embolization if it is underlying. So what are your key points for anesthetic and hemodynamic management of these patients, right? So we all know that we need to maintain sinus rhythm and avoid atrial fibrillation at all costs. Hence, a 5-lead ECG is extremely important for these patients, and it will be good to have a pulse oximetry also attached along with, which has a visible waveform coming to us. We need to address if there is a new onset atrial fibrillation and the blood pressure is dropping, cardioversion needs to be instituted immediately for hemodynamic stability. And all throughout the perioperative period, pain-induced tachycardia, ensuring adequate needs to be addressed by not only providing effective analgesia, but also ensuring adequate anesthetic depth, right? If the tachycardia is because of hypotension, then we really need to titrate our fluids depending upon the loss, and we do not want to move into hypervolemia at any point in time. And therefore, there is a role for use of phenylephrine and norepinephrine as vasopressors in these patients. Okay. For afterload, of course, as I said, we need to maintain a normal afterload. So we need to avoid hypotension, avoid sudden sympathectomy. So spinal anesthesia. I know there are some, when you go out and you work alone, there are some centers that do spinal laparoscopic procedures under spinal anesthesia. I would not advocate for these particular group of patients because this sympathectomy is going to be detrimental to this patient, especially if there is an underlying LV dysfunction. It will lead to myocardial infarction and major adverse cardiac events, right? And an intra-arterial blood pressure is important monitor for, which will give you a beat-to-beat monitoring for major surgical procedures, right? Of course, the vasoconstrictor of choice is something that does not cause tachycardia. So phenylephrine and norepinephrine are the mainstay vasopressors that we can use. And as I said before, avoid hypervolemia. So we do not want a preload. They're very preload sensitive. So a development of flash pulmonary edema can happen anytime. And therefore, we need to, one, monitor, and second, be able to manage. But the best is to avoid it, right? That's the mainstay. As far as myocardial contractility is concerned, we need to avoid doses of drugs that can cause a significant myocardial depression. So this patient have a tendency to go more often into right heart failure, and of course can also move into left heart failure. And therefore, inotropic support might be needed for these patients in case you find that these patients have gone into severe myocardial depression and RV failure. We need to minimize the pulmonary vascular resistance. We need to optimize our oxygenation and ventilation, and hypercarbia that is going to come up in a big way. So therefore, lung protective ventilation with rapid increased respiratory rates, which will avoid hypercarbia and at the same time take care of hypoxemia as well, are extremely important for these patients to ensure, adequate hemodynamics and perfect homeostasis. So to end, remember that when you have such a kind of a patient coming in, we need to look at the kind of mitral valve replacement done. Is there a prosthetic valve up there? What is the type and duration and the current status of its function up there? What are the type of surgery that we're looking at? What the risk of bleeding and the thromboembolism in this patient? And depending upon the type of prosthetic valve, the kind of anticoagulation, and the patient profile, thrombogenic patient profile, they all will decide whether this patient's risk for thromboembolism are high or low. And we need to, as a result of that, plan our anticoagulation strategy perioperatively. So whether or not we need bridging or stopping and restarting, at all times we need to keep a balance or a risk-benefit ratio between bleeding and thromboembolism. Remembering that thromboembolism is a major risk, and monitoring throughout from the preoperative to the postoperative period is extremely important. And you will need various forms of invasive monitoring, especially in intra-arterial monitoring. A 5-lead ECG are something that are very, very important. Remember to keep your patients warm, monitor your temperature, the end-tidal carbon dioxide. All of these form comprehensive monitoring for these patients. Tailoring your anesthesia, would prefer in this particular patient who is coming to you for a laparoscopic cystectomy, which is, and depending upon your surgeon, I would say it's a kind of a medium duration surgery with minimal risk of bleeding. So therefore, GA with, say, a second generation LMA would suffice. Of course, you need to monitor your patient well and maintain your heart rates and sinus rhythm with no tachycardia, a reduction in the pulmonary vascular resistance, as I said, maintenance of your afterload and myocardial contractility. and you need to prevent, monitor, and manage pulmonary edema, the more major complication that can occur at any point in time. So balancing all the risks of bleeding, pulmonary edema, and maintaining perfect hemostasis is what is very, very important. And with this, I leave you with these 3 main articles which have recently come up, and they give you a wonderful overview of how to manage not only patients with prosthetic valves, but also patients who are without prosthetic valves with various kind of valvular heart diseases coming to us for non-cardiac surgery. Right? I take this opportunity, and with the permission of the chair, would like to invite you all to PGI Chandigarh in 8th to 11th of December for the National Conference of the Association of Obstetric Anesthesiologists. Thank you all for a very, very patient hearing, and love to have questions. Thank you.
Thank you, Anju ma'am. And it was really extensive topic, but your flow charts and table made it look simplified, not only for PGs but in our routine practice for practicing anesthesiologist as well. And I don't see any questions on the chat box as of now.
Varsha, just 1
Yes.
minute. Can I take 1 minute? In spite of ill health of dear Anju madam, she has joined and she is there with us. Tons of thank you, madam. Thank you so much.
Thank you. Thank you. I had to, do your commitment. I was really looking forward to actually coming in person to Pimpri, and I hope I'll be able to join you all in future.
Yes, yes. Maybe next year we will plan, and you'll be there with us next year in physical. Thank you so much.
Thank you.
Thank you.
And congratulations to all of you. Thank you.
Yes. Thank you, madam. Thank you. Our pleasure. Over to you, Varsha.
Yes, thank you, ma'am. So now there are few instructions for the delegates, RPGs, that this webinar has got 2 MMC credit points. So in total, you will get 6 MMC credit hours, okay, provided you attend it till the end. And please don't leave the group, as in 10 days period, the certificates will be uploaded for online as well as physical webinar. Okay, there will be separate certificates. They will be provided to you, and it's our accountability. So I would like you all to keep patience, and we will definitely upload it in a week's time. Okay, so now I'll proceed with the next speaker now. I hope my screen is visible.
Yes, yes. Go ahead.
Yes.
Okay. So Dr.
Good.
Madhuri Kurdi, she is professor and head of Department of Anesthesiology, Karnataka Institute of Medical Science, Hubli. She is postgraduate teacher since 27 years and PG examiner. She is associate editor of Indian Journal of Anesthesia and assistant editor of journal JOACP. Sorry, I don't know the full form. So advanced courses in medical education and member of medical education unit as well. She is a part of medical education and research team. She has been the best peer reviewer award was awarded to her for ISA IJ in 2016-17 and ISA Proficiency Award in 2021. She has 80 indexed articles, 1 book, and 3 book chapters to her credit. So I'm really, privileged to have such a esteemed speaker today. So welcome, Dr. Madhuri Kurdi, and you can start sharing your screen. Ma'am, you are on mute.
One sec. Yeah. Thank you very much, madam, for that very nice introduction. I don't think I deserve so much, but it's a pleasure for me to present this talk on this prestigious podium of the West Zone Postgraduate Assembly. And I extend my sincere thanks to the organizing committee, especially Dr. Maya Bhalerao and Dr. Sumit Lad and the entire organizing committee for giving me this opportunity to present my talk today. So I'll start with my lecture. Yeah, is it visible?
Yes, ma'am.
Yes.
My screen is visible,
Okay,
and you are also audible.
I'll make it right.
Yeah.
So my topic is cirrhosis with portal hypertension for, one sec. I'm not able to go to the slideshow. Yeah. My topic is cirrhosis with portal hypertension for transjugular intrahepatic portosystemic shunt procedure, which is popularly known as the TIPS procedure. I think all of you must have heard this terminology, TIPS procedure, but I do not know in how many hospitals they are doing this procedure and how many of you postgraduates or even consultants have been exposed to this TIPS procedure. Now, this TIPS procedure, I will be telling you all the details about it, but it is mostly done by interventional radiologists. And as you know, interventional radiologists are not available in all hospitals, but it is a very useful procedure. And I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli, which is a premier postgraduate teaching institute of the government of Karnataka. So the TIPS procedure, it creates a shunt between the portal and systemic venous circulation. And the goal of this procedure is to create a shunt successfully and achieve a post-operative hepatic venous pressure gradient less than 12 millimeters of mercury. Now let's go to the ward. That is, let's see a case. Look at this case. Here there is a patient who is a 62-year-old chronic alcoholic, and he has history of jaundice for the past 6 years, and he is under conservative management for cirrhosis with portal hypertension. Look at this, the jaundice. It's very obvious, right?
Slides are not moving.
Madhuri,
The slides are not moving.
PPT presentation kara, madam.
It's not moving?
No, make the
Just one
PPT
sec,
presentation.
One sec. Since when have the slides not been moving?
No. Your first slide is seen now.
Okay, now what should I do?
Ma'am,
Make it a
we are not able to see any
presentation.
Dr. Madhuri, madam, please listen to me. You would have opened the slideshow mode.
Yeah.
You would have done that in a slideshow mode. But at the time of slide sharing, you have shared the presentation mode, not the slideshow mode.
Okay, so I have to share the slideshow mode.
You have to share the slideshow mode.
Okay,
The total number will not be there.
I will do it. I'll do it. Just give me 2 minutes time. I have to share the slideshow mode. Take it easy. No. Now let's see.
Madhuri, madam.
Just one second. Give me 2 minutes time. Give me 2 minutes time.
Okay.
Now just tell me, are my slides moving?
Yes. You can just.
Ma'am, this is first slide. Can you just next?
Now
yes. It is moving.
Yes.
Are they moving?
Yes.
Yeah.
Then that means I don't know. I will start all over again. I do not know how much I have come to, but I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli, which is a postgraduate teaching institute of the government of Karnataka. So first of all, what is TIPS procedure? TIPS procedure creates a shunt between the portal and systemic venous circulation. And the goal of the procedure is to create a shunt successfully and achieve a post-operative hepatic venous pressure gradient of less than 12 millimeters.
Madhuri, madam, just excuse me. There is some black square is seen on each slide.
I know, but I don't know. I can't do anything for that now.
We'll ask Dipen to help you out. Dipen?
I don't know how
Can you help Madhuri, madam? Because on each slide, otherwise it will be seen.
But it's not affecting anything much.
Okay,
I
then
don't
it's
think
okay,
it will
madam.
affect it much. Let it be there.
You can go ahead, no problem.
No, it will not affect in any way. Let it be there, no problem. Okay.
Okay, madam, no problem. Okay.
Okay, so now I think we'll continue now because already I have done twice. I have started.
Okay,
I
madam.
spent, I think, 10 minutes. I lost mine already. Okay, so starting with the case. Here is a 62-year-old chronic alcoholic patient with history of jaundice for the past 6 years, and he is under conservative management for cirrhosis with portal hypertension. So you can see the jaundice here, it is very obvious. This patient gives history of on and off hematemesis and melena for the past 6 months. On examination, the patient has pallor, pedal edema, clubbing, blood pressure 100/60, pulse rate 110 per minute, respiratory rate 22 per minute. Systemic examination per abdomen, inspection, normal contour, all quadrants moving equally. Abdomen is distended with enlarged veins and there is a fluid thrill. Look at the distended veins on the abdomen. Palpation, the lower border of the liver palpable with respiration below the right subcostal margin. It is firm and regular in consistency. On percussion, the liver dullness is noted at the 5th intercostal space mid-clavicular line, tympanic note. Auscultation, nothing very significant. Examination of the other systems, JVP is elevated, apex beat felt in the normal space, and the central nervous system is normal, respiratory system also, nothing very significant. Airway assessment appears quite normal, all the neck movements and distances are all normal. And coming to the investigations, the hemoglobin is 9 gram percent, INR 1.5, urea is 21, LFT's total bilirubin is 6, serum albumin is 2.5, SGOT 150 and SGPT 250. Ultrasonography shows gross free fluid in the abdomen with megaly and mild pleural effusion bilateral. So to summarize, this is a 62-year-old chronic alcoholic with history of jaundice for the past 6 years with hematemesis on and off and melena, suggestive of cirrhosis of the liver with portal hypertension. Now, what is the solution for this patient? So the most important problem that this patient has is hematemesis. Now, hematemesis in liver disease is an emergency, and you must have seen many of such patients, chronic alcoholics, coming to the casualty with hematemesis and complaints of bloody vomit. And whenever there is hematemesis in such a case, it always implies that the patient has significant portal hypertension. Now, the management in such an emergency situation, how will you manage such a case of emergency, such an emergency case with hematemesis in a patient with chronic liver disease? You have to follow the basic of resuscitation, take care of the airway, the breathing, and the circulation. Patients are often such kind of cases are often put on drugs like terlipressin, somatostatin, and octreotide. Now, the definitive treatment for such cases is emergency endoscopic sclerotherapy, or you must have heard of variceal banding, where the varices rubber bands are mounted at the end of the endoscope and the varices are crushed. Then I'm sure you have heard of all this, the balloon tamponade, where a Sengstaken-Blakemore tube is passed. This is the Sengstaken-Blakemore tube. You can see the esophageal balloon. This is the esophageal balloon. This is the gastric balloon. Okay, and this is you can aspirate the stomach through this particular port. You can inflate the gastric balloon here, the esophageal balloon from here. And in this way, you can compress the veins which are bleeding and put a stop to the bleeding which is taking place. Now, what is TIPS procedure? This procedure is one more procedure which is conducted by an interventional radiologist, and it is done in cases with severe hematemesis in a case of portal hypertension with liver cirrhosis. And in this procedure, what is done is that a metallic self-expandable stent is inserted between the branch of the hepatic vein and the portal vein, and this decompresses the portal pressure into the systemic vein. So the main thing is that you have to bring down the portal venous pressure, because it is the portal hypertension which is leading to the bleeding and all other signs and symptoms. So before we go on to the details of how to conduct the case, let us go briefly into the anatomy which is relevant to the case. Now, all of us know this, this is the cystic duct and this is the common hepatic duct which joins to form the common bile duct. And we know that as briefly about the blood supply of the liver. The liver, it's a very vascular organ receiving about 25% of the total cardiac output. In the exams, often they ask you, what is the total blood flow of the liver? You should be knowing. And most important to remember is the blood supply of the liver is dual. It has got a dual blood supply. One is from the hepatic artery and the other is from the portal vein. Now, the hepatic blood flow, the average is around 100 ml per minute for 100 gram of tissue. Out of this, the portal vein supplies a major part of the blood flow to the liver, that is around 75%, but the oxygen content of it is low, it is only around 50 to 55%. Whereas the hepatic artery, which is a branch of the celiac trunk from the aorta, delivers only 25% of the total hepatic blood flow, but its saturation is nearly 98%. And please remember that the mean portal venous pressure is around 6 to 10 millimeters of mercury, because if you have to understand the physiology of portal hypertension and the TIPS procedure, you should know what is the mean portal venous pressure. It is around 6 to 10 millimeters of mercury. So you should know, you see, this is how the portal vein is formed. The splenic vein is joined by the inferior mesenteric vein and the superior mesenteric vein from the small intestine and large intestine to form the hepatic portal vein. So now let us see briefly about the regulation of the hepatic blood flow. There is both intrinsic and extrinsic regulatory mechanism. The intrinsic regulatory mechanism includes the hepatic arterial buffer response, autoregulation, metabolic control. And extrinsic regulatory mechanism includes the neural control, humoral control. And now let us see what is the hepatic arterial buffer response. This is very, very important in the regulation of the hepatic blood flow. Well, what is HABR? See, changes which occur in the portal venous blood flow will cause reciprocal, that is ulta changes in the hepatic arterial flow. That means suppose the portal venous blood flow decreases, the hepatic arterial flow will increase and vice versa. And how does this occur? This occurs by synthesis and washout of adenosine, which is a vasodilator in the region of the porta hepatis. And please remember that halothane inhibits this hepatic arterial buffer response, and some other volatile anesthetics like isoflurane, sevoflurane, and desflurane, they do not inhibit the hepatic arterial buffer response. Then comes the pressure flow autoregulation. We all know what is autoregulation, the cerebral autoregulation, the coronary, and so on. Now here what happens is, whenever the transmural pressure increases, say due to hypertension, what happens? There is a stretching of the arterial smooth muscle, and this resultant increase in myogenic tone prevents the increase in the organ blood flow. Now, what are the factors that increase the hepatic blood flow? Postprandial, hypercapnia, acidosis, and recumbent position will cause an increase in the hepatic blood flow. Decrease in the hepatic blood flow, most of the anesthetic agents, surgical trauma, especially the retractor, which is used in intra-abdominal surgery, positive pressure ventilation, PEEP, hypocapnia, alkalosis, and hypoxia, all these can cause a reduction in the hepatic blood flow. Now, briefly, I think all of us know what is the porta hepatis. It is the area with the portal vein, hepatic artery, and bile duct. All of them will be there in the porta hepatis. Vein and artery will enter the liver and the bile duct will exit from there. And please remember that the portal vein divides into the left and right portal veins, and their final branches will be located within the portal tracts which drain into the liver sinusoids. And through the liver parenchyma, the blood drains into the central hepatic veins. See over here. This is the hepatic artery, which is dividing, and then the portal vein, which again divides, and then the blood. Look at this. This is the portal triad where you have all these three vessels, and then the blood drains through the sinusoids and then through the hepatic parenchyma to the central vein. Now, if you see the pathophysiology of cirrhosis with portal hypertension, portal pressures are measured. I already told you about the hepatic venous pressure gradient. It is the pressure between the free hepatic vein and the pressure in a wedged hepatic vein. And the normal value of HVPG, please remember this, is always less than 6 millimeters of mercury. And when this pressure, when this gradient, HVPG gradient, when it becomes more than 10 millimeters of mercury, esophageal varices will be produced and they will start bleeding when the pressure exceeds 12 millimeters of mercury. So whenever there is liver injury, fibrosis is produced and the vascular resistance increases. Similarly, in cirrhosis, angiogenesis occurs, sinusoidal remodeling, and then there is an increase in the vascular resistance. So portal hypertension, there is an increase in the HVPG. The portal pressure further increases. Collaterals are formed. Native blood flow increases. Vasoconstriction occurs. Again, there is portal hypertension, and then this vicious cycle continues. So this portal hypertension, why it is dangerous? Because it has got some deleterious effect on other systems. On the cardiovascular system, there is a lowering of the systemic vascular resistance and resulting in a high cardiac output state. Intrapulmonary and arteriovenous shunting occurs and pulmonary hypertension occurs. The pulse will be bounding, there will be tachycardia. Then the bile acids, you know that they will have negative inotropic effects. The bilirubin is said to have a natural antioxidant effect, but the bile salts, they cause bradycardia and prolongation of the QT interval. And coming to the effects on the central nervous system, due to the accumulation of neurotoxic compounds, what happens is hepatic encephalopathy can be precipitated, especially by a GI bleed or dietary protein overload or infection. And this mainly occurs because the neurotoxic compounds are diverted from the portal venous flow through the collateral vessels. And I think these signs of hepatic encephalopathy you already know, and I'm not going to tell them in details, but there are 4 grades of hepatic encephalopathy which you should be knowing, ranging from mild confusion to increasing confusion, and finally the patient becomes unarousable with signs of cerebral edema. In the respiratory system, there will be intrapulmonary AV shunting, I have already told you, and the ascites causes diaphragmatic splinting, and there may be hepatopulmonary syndrome, and because of all this, the patient will often have hypoxemia. The hepatorenal syndrome, what is it? There are 5 major criteria to confirm its diagnosis, and it occurs mainly due to hypotension and hypovolemia. Most important, the serum creatinine will be more than 1.5, and there will be proteinuria less than 500 milligram per day, and there should be no ultrasonographic evidence of parenchymal renal disease or urinary obstruction. GI system, there will be esophageal varices, splenomegaly, and whenever ascites develops, you should know that the hepatic decompensation has started occurring. And look at these, the dilated veins, you can see the spider nevi, all this you have studied in your undergraduate days. These are the esophageal varices, the endoscopic image, the cherry red spots on the esophagus, and the fundus varices. And these are the ones which start bleeding when the portal venous pressure increases. Hematologically, there will be anemia, coagulation defects, including thrombocytopenia, platelet dysfunction, and the treatment is, of course, vitamin K and fresh frozen plasma. Then the absence of bile in the intestine makes the bacterial flora in the intestine grow. The GI mucosal barrier breaks down and bacteria translocate into the systemic circulation and endotoxemia occurs. Wound healing is also delayed in such cases. Now, what are the preoperative risk factors which are associated with increased postoperative mortality in these cases? Serum albumin less than 3, presence of infection, white blood cell count more than 10,000, prothrombin time more than 1.5 seconds, serum bilirubin more than 50, presence of ascites, malnutrition, and weight loss, they herald increased postoperative mortality. Surgical risk factors depends upon the type of surgery, emergency, intra-abdominal surgery, non-laparoscopic surgery, MELD score more than 8, child PUG score more than 6. All these are risk factors for increased mortality. So preoperative risk assessment is very important in this case. And as usual, I think you all know about these metabolic equivalent tasks. MET scoring is very important. Then comes the Lee's revised cardiac risk index scoring. This also can be done. And the two risk stratification schemes, which are very important in a liver case, especially in patients with cirrhosis, is the modified Child-Turcotte-Pugh scoring system and the MELD score, that is the model for end-stage liver disease. Now, if you see the Child-Turcotte-Pugh scoring system, it has got 5 criteria: encephalopathy, ascites, bilirubin level, albumin level, and prothrombin time. So if the Child-Turcotte-Pugh score, maximum points you can get is 15. So if it is class A, it is least severe liver disease, class B is moderately severe, and class C is most severe. So if it is class A, elective surgery is well tolerated. If it is class B, it is only permissible with adequate pre-op preparation, and class C is considered only for emergency surgery. Now, what is this MELD score? This is an objective assessment in predicting 3-month mortality. I have put the formula here for calculating the MELD score. If it is less than 14, the best outcome. If it is 15 to 24, then further discussion is necessary before you go on. Now, coming to the preoperative investigations, to assess the general condition of the patient, hematological investigations are necessary: the hemoglobin, platelet count, clotting factors, cardiorespiratory, chest X-ray, ECG, ABGs and echocardiography, and metabolic serum protein, serum glucose, electrolyte, urea, creatinine. To know the pattern of disease, bilirubin, and all these liver function tests. To judge the synthetic ability of the liver, albumin globulin ratio, prothrombin time, INR, and then there are some other tests which of course are done for some special cases. Now, coming to the preoperative preparation, I already told you the child is grading. So you do the grading and then you assess the hydration status, correct anemia, coagulation, and hypoproteinemia, arrange appropriate blood and blood products, and you inform the patient, discuss with the patient the possible post-operative complications. Now, the optimization before surgery, the patient is definitely going to have ascites, which has to be drained if necessary, hydrothorax, encephalopathy, anemia, coagulopathy, electrolyte imbalance is to be corrected, nutritional deficiency is to be corrected, abstain from alcohol, and continue. Mostly the patient of portal hypertension will be on beta blocker, continue it on the day of surgery. Coagulopathy, treat with vitamin K, 10 milligrams subcutaneous, FFP if you need emergency correction, platelet transfusion if thrombocytopenia, cryoprecipitate and DDAVP can also be used. You can also use thromboelastography intraoperatively. And preoperatively, I told you the malnourishment has to be corrected. Now, what are the anesthetic goals? Main thing, please remember, this is a mantra of managing any hepatic case. Maintain hepatic blood flow, avoid hypotension, hypoxia, avoid hepatotoxic agents, and try to avoid all use a technique which maintains the hepatic blood flow. Amongst the volatile agents, halothane causes a lot of cardiovascular depression and the greatest reduction in hepatic blood flow. Isoflurane, sevoflurane, desflurane are permissible. Worst is halothane, and followed by enflurane, desflurane, iso, and sevoflurane. Nitrous oxide also causes a decrease in hepatic blood flow, so be careful. Thiopentone, not very significant changes. Propofol reduces hepatic blood flow in dose-dependent manner by producing a fall in the blood pressure. Ketamine decreases hepatic blood flow. Etomidate, not much effect. Opioids, pentazocine, morphine increase the blood flow. Pethidine decreases the hepatic blood flow. Pre-medicate, if patient is not having encephalopathy, you can give a mild oral anxiolytic, otherwise just avoid all these things. Oral H2 receptor antagonist can be given. Mannitol, 100 ml of 20%, 2 hours pre-operatively, bilirubin is more than 8 mg%. Monitoring routine is NIBP, pulse rate, ETCO2. Temperature monitoring is important, urine output, and neuromuscular monitoring. Arterial pressure monitoring and CVP monitoring only if the patient is very bad. So monitoring again, pulmonary artery catheterization, transesophageal echocardiography for ejection fraction, preload, regional wall motion abnormalities depending upon the condition of the patient. Fluid balance, large bore IV access is mandatory. Try to warm the fluids. And please remember that colloids, they will produce less bowel edema and they will improve the mesenteric perfusion, rapid restoration of gut function. And the effect of hepatic dysfunction on the anesthetic drugs, remember that the protein binding is altered, the volume of distribution is altered, and the drug metabolism is altered. So drugs with high hepatic extraction ratio like propofol, lignocaine are markedly affected by changes in hepatic blood flow. And regarding inhalation anesthetics, I have already told you desflurane has less oxidative metabolism than isoflurane, and it can be used. Halothane hepatitis, I think you have heard of this terminology. It is there in the old books. Halothane, its metabolites react with hepatocyte proteins, and then there is an immune response resulting in hepatocellular damage. It can manifest with mild and in the fulminant form, halothane hepatitis. And if it is fulminant, it can lead to mortality. Intravenous agents, I have already told you. Thiopentone can be used, but the dose should be reduced. Propofol also dose should be reduced. Midazolam, there will be prolongation of the effects. Opioids, all opioids cause an increase in the tone of the common bile duct and the sphincter of Oddi. Morphine, exaggerated sedative and respiratory depressant effects. Remifentanil is best because it's the ideal opiate for use in patients with liver disease because it is metabolized by tissue esterase. Fentanyl, sufentanil are safe at lower doses. Neuromuscular blockers, succinylcholine will have a bit prolonged effect. And best is to use atacurium, cis-atacurium because they do not rely on hepatic excretion and they depend upon Hoffman elimination. Mechanical ventilation, use lung protective ventilation, use low tidal volumes, PEEP only up to 12 centimeters, not more than that, because that will cause a reduction in the hepatic blood flow. Anesthetic management of tips. I just have a small video which you can hear. I don't know whether it's playing. Okay, it cannot play. We will see afterwards. I'm not able to play it. I'll go ahead. But I've already told you what is TIPS procedure, where a stent is passed from the internal jugular vein. The internal jugular vein is cannulated, and from there they enter the right atrium and the inferior vena cava, and from there they enter the hepatic vein, and then they go towards the portal vein. And a metallic stent is placed, and in this way, the blood is diverted from the portal circulation to the systemic circulation, and in this way, the portal venous pressure is brought down. So if you see the pre-anesthetic evaluation of these patients, you have to do a neurological evaluation, cardiovascular, respiratory, renal, GI evaluation, and hematological evaluation, which I have already told you. So I'm not going to tell you again. But please remember that if the patient has hepatic encephalopathy, it is likely to worsen after TIPS procedure. So one of the main problems of TIPS procedure is because the blood is diverted from portal to systemic circulation, the toxic agents are diverted directly to the systemic circulation, and this will cause worsening of hepatic encephalopathy. And that is one of the bad points of TIPS procedure. And the overall hepatic encephalopathy incidence has been found to be 36% at 6 months, but it slowly decreases after 12 months. The cardiovascular evaluation, I have already told you, the ECG, the transthoracic echocardiography should be done to see if there is any pulmonary hypertension, biventricular function, and try to look for ECG changes, because if the patient already has ECG changes, it is very likely that when the shunt is being passed through the jugular vein and the atrium and the inferior vena cava, there can be arrhythmias, and if there is a pre-existing bundle branch block, it can exacerbate. So keep pacing support ready. Then if there is refractory ascites, again, it is going to cause respiratory problems, and you may have to bring down the ascites by draining the fluid. Renal evaluation, I have already told you. And please remember that any patient with refractory ascites, this is a very good indication for performing for doing the TIPS procedure. And so the indications for TIPS procedure include secondary prevention of variceal bleeding, refractory ascites, refractory acute bleeding varices, portal hypertensive gastropathy, and bleeding gastric varices, hydrothorax, and hepatorenal syndrome. Contraindications: absolute is primary prevention of variceal bleeding, congestive heart failure, uncontrolled systemic infection of sepsis, unrelieved biliary obstruction, and severe pulmonary hypertension. Hepatoma, portal vein thrombosis, thrombocytopenia, and moderate pulmonary hypertension are relative contraindications for TIPS procedure. So I told you in this procedure, In case ascites is present, you do a therapeutic paracentesis first so that your vascular cannulation becomes easier. Either the left or right internal jugular vein is accessed with ultrasound guidance, and usually the right vein is cannulated. Then the catheter is directed to the portal vein, and after balloon dilatation of the parenchymal tract, a stent graft is deployed. And during the TIPS procedure, they will use advanced imaging technology like intravascular ultrasound and intracardiac echocardiography. So in the intravascular ultrasound, the catheter is passed through the vessel, and this vessel, there is a probe which the ultrasound probe will be directly inside the vessel. The procedural complications of TIPS procedure include hypotension due to bleeding due to portal vein rupture, anesthesia-induced hypotension or decreased preload when you have tapped a huge ascites. Atrial or ventricular ectopics can be there, and post-TIPS there can be increased venous return, and this can exacerbate a heart failure. Intraoperative management, large bore venous access, arterial cannulation for continuous blood pressure monitoring, and you have to secure the airway. You have to intubate the patient. Do not use supraglottic airway devices. So general anesthesia with endotracheal intubation is preferred. Rapid sequence induction you have to do, because remember there will be an ascites, so there will be increased intra-abdominal pressure, so risk of aspiration. Maintenance with inhalational volatile anesthetic agents. Maintain normothermia with warming, because if there is hypothermia, the bleeding and the coagulopathy which is there is going to cause a lot of bleeding. And soon after TIPS procedure, you will see that everything will come down. The varices will come down, the varices will come down, and the ascites will decrease, the hydrothorax will decrease, and all the signs will come down. Post-operative analgesia, remember that TIPS is actually, as I told you, it is done by interventional radiologist. It is a minimally invasive procedure. So you can give post-op analgesia with opioids, NSAIDs, and other routine analgesics. Fentanyl, sufentanil are quite safe. And remifentanil is metabolized by tissue esterases. So it is the ideal opioid for patients with liver disease. So to conclude, anesthesia in liver cirrhosis and portal hypertension can be very challenging, and meticulous attention on optimizing the patient's condition preoperatively, doing a good preoperative risk assessment, and choosing appropriate anesthetic regimen, monitoring, and drugs can lead to better patient outcomes. So these are my references, and thank you very much.
Thank you, Kurde Madam, for a wonderful presentation. I would like to welcome Dr. Manisha Katekar Madam, the President of Maharashtra State Chapter ISA, who has joined the webinar. Welcome, Madam. Varsha, I think now you can proceed with the other lecture.
Thank you so much. Thank you so much. I'm really enjoying the third consecutive day. It's a wonderful academic shift. RTS congratulations, team ISA Impressions.
Thank you. Thanks a lot, Madam.
Thank you, ma'am, for joining us. And I thank Madhuri Kuldi, madam, for such a wonderful presentation. There is some background noise. Can everyone else mute themselves? Yeah, thank you so much. Okay, so there are no question and answers, Madhuri, ma'am. So we can proceed to the next speaker.
Okay.
Okay. So Dr. Lipika Singh, I would request our speakers to stick to timeline as we are already lagging behind the schedule. So now I would like to welcome our next speaker. My PPT is visible? Yeah. So Dr. Lipika Baliar Singh, madam, she's MD Anesthesiology, working as a professor in Topiwala Medical College and Nair Hospital, Mumbai. Her specialty is in cardiothoracic anesthesia, vascular surgery, and transplant anesthesia. Her hobbies are poetry, writing, reading, and Odissi dance. Wow. So I welcome you, ma'am, for the topic of thyroidectomy in patients with hyperthyroidism and large goiter. So over to you, Lipika, ma'am. I'll stop sharing.
One second, I'll share the slide.
Yes, ma'am.
Just share.
It's visible, ma'am. Just check if you can scroll down, make a full PPT view. It's seen in the editing mode.
I think it is.
Yeah.
It is happening.
Right.
Yeah, first of all, thanks a lot to all the organizers, to Maya Madam and Sachin and the enthusiastic team. I know we all are lagging behind, but I just kept all the materials intact because to be uploaded at one place and the continuity will be there. So we will just go for the case discussion of patient with hypothyroidism with large goiter for thyroidectomy. To this discussion, a 55-year-old male patient for total thyroidectomy was posted with history of gradually enlarging midline neck swelling since 10 years. Restlessness, palpitations initially, now controlled with medications over these years with different antithyroids. And he has difficulty in breathing in supine position. This is an important history to note. And he has got hoarseness of voice since 1 year. He is diagnosed with hyperthyroidism since 8 years, and he is on neomarcazole 10 milligram BD and propranolol 20 milligram twice BD. Examination was the thyroid BMI of 23.2. Important hyperthyroid patients as the BMI increases in this condition, and the vitals were within normal limits. The sleeping heart rate is 90 beats per minute. Usually it goes high in patient who is not controlled. It is in regular rhythm, so there is no atrial fibrillation or no atherosclerosis deficit. At TUTO examination, you can see on the right side, these are the various organs and signs and symptoms have to be checked accordingly. I'm not going into details of all that, but the main prominent features will be eye signs in these patients. So he had exophthalmos and he had serious features like PTVL myxedema, though he didn't have any fine tremors because he was well controlled with medications. He didn't have any other signs of hyperthyroidism. In the systemic examinations were within normal limits. He had no signs of congestive heart failure, hyperdynamic circulation, or cardiac murmur. And there was no stridor. The trachea could not be palpated though. So these are the triads of, look at this carefully, the triads of Graves' disease where diffuse goiter should be present with ophthalmopathy and PTBL myxedema. This is the classic feature of a clinical triad of Graves' disease, which you should be able to answer always. So these are the typical features, and the patient is in real distress if these features are present. And we must always be able to detect it and optimize it. That is our goal. So coming to the airway examination, the predictors of difficult mask ventilation and difficult intubation have very low to moderate predictive value actually in these patients. In this particular patient, he had normal mouth opening and he had modified myelopathy grade of 3. Thyromental distance obviously could not be assessed. Neck movements were restricted due to the neck mass, and mandible accession score was assessed and it was within normal limits. So as we know, these patients there was the palpation by Grimes method where we check on the surface of the gland and we check for the consistency, and the Cocker's test where we check for the which is used for multinodular goiter, and infiltrating CA, which is typically seen in scabbard trachea, and the percussion and auscultations are done. So important is Pemberton's sign, which is elicited when the patient elevates both the arms until they touch the sides of the head, and that happens that leads to facial congestion, and this is a typical thyroid cord effect which happens in the thoracic inlet, and it is little risky, but the Pemberton's sign should not be it should be checked and it should not be missed. So the usual investigations, routine biochemical investigations and specific investigations typical to thyroid like TSTs and serum calcium should be done, and details of cardiovascular status investigations are required, and radiological investigations for airway assessments are required. So these are the routine biochemical tests which we do. And as you know, the normal range of TSH, T3, T4, and FT3, FT4, they're all within normal limits, but you have to know the range. The TSH is the main. I'll discuss it little later. The TSH was within normal limit here, but this patient was under treatment. So we must remember the values and the units of T3, T4, and FT3, FT4, and we have to interpret it along with the clinical signs. Coming to the important investigations pertaining to the CVS, ECG was in this patient didn't have any tachyarrhythmias or no other arrhythmias, and there was left axis deviation secondary to hypertension. 2D echo showed EF of 60%, but the patient was not in atrial fibrillation. And the radiological investigations of the external and epilateral view I'll show later. And the PFT and flow volume looks were done. And CT scan neck and upper thorax showed no retrosternal goiter, no tracheal narrowing at the level of C2, and the narrowest diameter was 6.75, with tracheal deviation to the left. And indirect laryngoscopy showed a decrease in the vocal cord, deviation applies to the left. Pictures of X-ray and indirect laryngoscopy picture. So our diagnosis was a 55-year-old male with large thyroid goiter. Graves' disease is the etiology, with airway compromise with decreased left vocal cord mobility and without complications like retrosternal extension or SVC syndrome, with controlled hyperthyroidism on anti-thyroid medication with no other comorbidities for elective total thyroidectomy. So what are the importance of history and physical examination? Because in such a condition, this endocrinal disability gives rise to so much, this is a vital hormone which has effect on all the entire organs of the body. So whenever we are coming in handling such a patient, we have to look at the duration and the gravity or the intensity of the disease which has affected each and every organ of the patient. So coming to the size and duration of the swelling, usually we have to look for the pressure effects on trachea, which is very important for us. That will be manifested as dyspnea hemoptysis stridor, that is the effect on change in position, which is elicited. And the pressure effect on esophagus by dysphagia, and the pressure effect on RL, recurrent laryngeal nerve, by hoarseness, which this patient had. And long-standing tracheomalacia, which we dread always, and of course sudden onset increase of size of the swelling, thyroid swelling or bleeding, that we have to look for to rule out malignancy. And of course the retrosternal extension is the most dreaded complication of this disease, which is hidden from everybody, from surgeon and for us, and it can give rise to surprises, because there the dysphagia is more enhanced, dyspnea is more enhanced, and SVC obstruction symptoms are present. And of course the intratracheal extension, which happens in cancerous patients, gives rise to dyspnea and hemoptysis. And we have to know the thyroid hormone status. Our aim is always to make thyroid, but we should not be missing out on any hypo or hyperthyroid state, and that we have to correlate clinically. And the associated endocrine abnormalities, as we know, in type 2A, 2B, should be always checked for and ruled out. Coming to the preoperative evaluation, the thyroid function status is a must, and airway assessment and retrosternal goiter presence and extent. And airway assessment, as I discussed before, all the pressure effects and the radiological investigations should be very thoroughly done and observed. And coming to the drug ingestion, amiodarone is the culprit many times, and the ingestion of PAS and sulfonylureas also influence the thyroid function. Coming to the thyroid biosynthesis and secretion of thyroid hormones, like this thyroid releasing hormone acts on the pituitary gland TSH release, and that goes and acts on the T4 and T3 of the thyroid gland. and then that gets converted, T4 gets converted to T3 in the peripheral tissues, and then they have a feedback effect on the hypothalamus and pituitary respectively. So when we are checking on, there are various steps starting from the iodide transport to secretion of the hormone, but usually we focus on the peroxidase step because all the antithyroid drugs, they act on that enzyme, and usually through that only the drug, the thyroid secretion gets T3 T4 ratio, and the secretion gets managed by the drug effect, and the effect on the oxidation and organification and coupling. These three steps are affected by them. So coming to the thyroid hormones, they are the essential hormones in the body, and about 90% of the thyroid hormone is T4, then T3 is about 9%, and it is 10 times more active than T4, as we know. And up to 80% of the T4 gets converted to T3 in the peripheral organs. And that we check by TSH assay, T3, T4, thyroid binding globulin, and antibody titers. And usually all these anti-TPO, anti-TSH receptors, they are done to know the presence of Graves' disease and Hashimoto's disease, and they are usually done very routinely nowadays. So we know the type of the disease now. So we can differentiate between Hashimoto's and Graves'. So coming to the interpretation of the TFT pertaining to hyperthyroidism, so we look at the serum TSH. If it is low, then it is a hyperthyroid state. And then we go to look for 3T4, 3T3. If it is normal, then subclinical hyperthyroidism. If it is high, then obviously hyperthyroidism. They can be, the subclinical hyperthyroidism can be diagnosed or undiagnosed. And when it is hyperthyroidism, it can be also untreated and treated. So if it is untreated or not treated adequately, they can go into thyroid stum when they are getting operated, or when they are not subclinical hyperthyroidism, when they are not diagnosed, they also can go into thyroid stum. Always keep on evaluating the TSH and T3, T4 and FT3, FT4 in a particular time frame. These are the other investigations for thyroid function status. This is the USG scoring for the gland size and pertaining to malignancy, and FNAC is done to rule out malignancy usually by the time they come to us, and whenever is done for the vascularity of the gland. Coming to the pathophysiology of hyperthyroidism, as we know, primarily there is alteration with the thyroid gland causing thyroid hormone secretions due to Graves' disease and toxic nodular goiter and toxic adenoma. And there can be acute painless thyroiditis also, which can happen due to post-viral thyroiditis. Like in COVID time also, it was very common. And it can be painless thyroiditis, typically seen in subacute lymphocytic thyroiditis, where there is increased anti-TPO antibody. And in pregnant patients also, it can be common. Secondarily, hypothalamus pituitary disorders which rise to TSH production gets increased in them, and drug-induced when somebody is taking thyroxine, in spite of having decreased requirement also, if the drug amount becomes more, it can give rise to hypothyroidism, and mostly amiodarone, usually iatrogenic drug. And now it is becoming very common along with the post-COVID, this contrast and these procedures where iodinated containing radiological contrasts are being given. That is known as Jord-Bezdo effect, where the common dose of IV contrast, that is usually 13,500 milligram microgram of blue iodide, is given, which can give rise to a temporarily increased state of hyperthyroidism state. Otherwise, interleukin-2, interleukin-alpha, which is given in the treatment of sepsis and cancer, also can give rise to this state, and use of lithium. So coming to the causes of goiter, as we discussed discussed. I'm not going into details of all this. Coming to just the main difference between primary thyrotoxicosis and secondary thyrotoxicosis. Primary usually has CNS symptoms with predominance, and secondary thyrotoxicosis, as you know, usually has CVS symptoms like palpitations, ectopic beats, and fibrillations, and dyspnea on exertion, and gradually going into CCF and rapid irregular pulse rate. The usual signs and symptoms are affecting all the organs. Usually, it is diagnosed with weight loss, and the BMR can go up to rising in more than 100%, and protein catabolism is present. The patient becomes catabolic, and there is extreme fatigue, and then these patients have a lot of proximal muscle wasting, which is out of proportional to overall weight loss. That is thyrotoxic myopathy. This we have to keep in mind because it affects the drug distribution and our calculation of the muscular NMDs also. And there is a typical restlessness and heat intolerance, and they really suffer, like the tremors of the palms coming to the tongue, and they have very shortened reaction time of stretch reflex. They have very brisk deep tendon reflexes, and they have electrolyte imbalances and diarrhea. So these are on the right side. I have just mentioned about all the symptoms which you see. Then typically coming to the cardiovascular manifestations, there is a rise in sleeping heart rate, and usually supraventricular dysrhythmia is present, and atrial fibrillation is the most common this rhythm we see there of heart rate and here is always and there is increased pulse pressure difference, increased systolic and decreased diastolic. And pulmonary hypertension is seen in 70% of cases in females, and that usually responds to treatment. Like if they are on antithyroids, then pulmonary hypertension comes down. And there is, of course, presence of hyperdynamic circulation, which is a concern. There is increase in CO2 production and minute ventilation, and the ventilatory drive also seems to account for the dyspnea and exertion. And then this responds well to beta blockade. So that at least the good thing is, by adequate optimization with antithyroids and beta blockades, we can at least treat the symptoms before we take up for anesthesia. These are just for the exam purpose. These are various eye signs which are usually asked for, like Darlington, Rosenbach's, Geoffroy's, Mobius, and Von Graf's and Stelwick's. And the typical Graves ophthalmopathy has to be remembered because it gives rise to ophthalmoplegia and diplopia. Coming to the medical management, usually the patient gets euthyroid, then only we take up for elective surgeries, and they are on various doses of propylthiouracil, methimazole, and carbimazole. Neomeprazole, that is 5 milligram of carbimazole, is the active ingredient. And the effect is usually assessed by the weight gain and the decrease in the serious symptoms and sleeping pulse rate, and of course the temperature. Then their mechanism of action, they inhibit the ironization of tyrosine residues and coupling to form the T3, T4 as we discussed before, and usually improvement is seen within 1 to 2 weeks. So these are ideas which are here in details. We can go to later. Then radioactive iodine, where the medical management fails, and it is usually indicated in grapes and toxic multinodular water. Coming to the airway assessment, which are main area of concern, we do X-ray neck epilateral to look at the trachea and looking for the displacement done by the thyroid, trachea, and esophagus. And CT scan of neck and upper thorax determines the retrosternal extension, and we get the accurate site and degree of airway compromise. And of course, we have to determine the tracheal diameter to be guided regarding the placement of the tube, and we have to look at if there is any presence of any narrowing and any distortion, compression. And here we look for any feature of malignancy, because that gives rise to difficulty in intubation. And MRI, of course, gives the good idea about the location and extent. And virtual bronchoscopy gives an idea about a dynamic obstruction when they reconstruct the multi-sliced CT slices. Coming to the other investigations like pulmonary function test, flow volume loops, flexible nasoendoscopy is also very helpful in making us understand the glottic opening state. And indirect laryngoscopy gives the documentation of vocal cord function, which is usually done by ENT people preoperatively. Coming to the flow volume loops, here it is already discussed before. Just to emphasize, extrathoracic obstruction, which is variable, is seen here by the flattening in large goiter and in retrosternal goiter. In the upper part, you see the intrathoracic obstruction is present, and that gives rise to flattening in the upper part of the curve. So, are all goiters risk factors for difficult endotracheal intubation? No, not at all. This is a very good article which emphasizes on these points that predictors of difficult phase mask ventilation and difficult intubation have only low to moderate predictive values, and only the cancerous goiter can give rise to difficulty in intubation. Otherwise, the Graves' disease or deep goiters or to give rise to difficulty in intubation scenario. So this we should not be missing at all. These two criteria like cancerous goiter and Cormack-Lyon bed 3 or 4, they were independent risk factors for difficulty in endotracheal intubation, we had found out. And the size of the goiter was not associated with DEI state. Of course, retrosternal goiter, if it is present, then we have to, as we know, the part which goes below the thoracic inlet is known as the retrosternal goiter. And these are the anatomic location which helps in the suggested surgical approach. So we know our the incision we know, and we can plan the anesthesia better because manubrio-tomy and sternotomy might be needed depending on their extent. So the diagnostic features are there. They are little more intense and severe symptoms, like when they are extending down and down into the thoracic inlet. So these are the diagnostic features we get from all these investigations. And the most unwanted picture, like the SBC compression, which happens by raising the hands above the head, like by those tests we can make out. There is edema, dilated veins on head and neck, and there is severe airway edema, severe obstruction due to airway edema, and venous access in the lower limb or femoral central line has to be put in these patients, and it should not be missed out. So this SVC obstruction, which happens due to retrosternal goiter presence, should not be missed out. Of course, when the goiter reaches till the carina, then we go for the CT bypass standby. So what is the anesthesia management of thyroid goiter? Like, we have two choices: general anesthesia or regional anesthesia. Actually, when we go to nowadays, everybody practices more regional anesthesia techniques. I'm not going into details of it, but just validating where it can be used. It is said that it is beneficial for medically compromised patients, and it is actually being practiced. And the obstructive symptoms, wherever the obstructive symptoms are secondary to very large goiters, to avoid the risk of GA, this can be practiced, provided we can have access to at least few landmarks, anatomical landmarks. Otherwise, cervical epidural is a good choice, but along with it comes the complications of it, like bradycardia and hypotension. And it should be given through a very experienced hand, and proper drug doses should be given. Otherwise, bilateral combined block of superficial and deep cervical plexus block can be given. So this has to be discussed, and then the surgeons have to be taken into consideration of time and fast, and like not very comfortable, like how they become in GA. So all these to be discussed and to be and the patient has to be cooperative also. So when is the patient adequately optimized for general anesthesia? It depends on the thyroid function status and timing of surgery. So as we know, when do we when do we give anesthesia, like depending on elective, semi-elective and emergency surgeries. As we know, our target is FT3, FT4 has to be within normal range and PSH is not considered here. And usually for semi-emergent, we schedule it after 2 weeks because we know with antithyroid drugs, the level will be achieved. And the therapy started with iodine. High concentration of iodine usually decreases all phases of hormonal synthesis, release, and shrinks the gland and makes it firm and less vascular. So surgically also it becomes better and easier for them to handle, and there's risk of thyroid storm. And the peak effect happens within 15 days, and there is worsening of hyperthyroidism and multinodular goiter, it is said, because the thyroid escape happens. So it has to be operated within that much time only. And mostly the Lugol solution is being used, which is given 3 drugs TDS for usually 10 to 14 days. That is a combination of 5% iodine and 10% potassium iodide solution. And iodide, that is a sodium potassium combination, also can be given. That inhibits the peripheral conversion of T4 to T3. And all these are very much time bound. If this treatment is given, then the surgery has to happen. And anybody who is allergic to iodide, like lithium carbonate 300 milligram per oral 6-hourly can be given. And if the patient has to be taken off for some emergency surgery, then usually we have to combine the beta blockers along with the antithyroid. Usually we go to treat the CVS symptoms or to prevent the CVS complications with IV esmolol, that is 0.5 to 2 milligram per kg range. And that inhibits the peripheral conversion of T4 to T3. And another good accompaniment of IV glucocorticoid, that is dexamethasone 2 milligram every 6 hours, is a big help along with the antithyroid drugs. And what are the anesthesia concerns? We have to avoid sympathetic stimulation like drugs which can give rise to sympathetic stimulation, atropine, ketamine, epinephrine, and pancreas. The thiopurine is supposed to be helpful, like good, because thiourinary nucleus decreases the peripheral conversion of T4 to T3, and we have to monitor the depth of anesthesia. And maintenance, usually inhalational is okay, but propofol dexmedetomidine combination is also quite good. And it is said that volatile anesthetics have increased MAC in these patients, but it is not yet so much supported by any literature data. So the usual MAC we can achieve, usually within 1.5 or 1 or 0.8 also can be okay. And hypotension is treated with direct acting vasoconstrictors, and intraoperative hypotension is usually treated with phenylephrine or phenine. And we have to avoid all these drugs very small bolus, small low doses, not in large boluses. And NMT is a must, as there is a reduced requirement for these patients of non-depolarizers, and their muscle wasting and atrophy is present, so the requirement goes down. And dexamethasone 2 milligram IV 6-hourly reduces the hormone release as well. It inhibits the peripheral conversion of T4 to T3, as I had told before. And here the concern is about the patient organ toxicity secondary to increased drug metabolism. And hepatotoxicity may be a concern, though it is not proven, but we have to be very precise with our drug delivery. Since half-life of T4 is up to 8 days, following the thyrotoxic gland removal also, we have to look for the evolution of thyrotoxicosis, prevention or detection of it. So coming to the main airway management, which is a challenge here, from intubation to after putting the tube, also the dislodgement of perioperatively, and of course extubation also here is a very big challenge, and again re-intubating due to the post-op problems. So all it is quite a prolonged stress for putting and maintaining the airway. So these are the preparation of the operation theater when we prepare for any thyroid case, like different kind of laryngoscopes, and we need a towel clip to lift up the huge thyroids, and and there is always a difficult airway cart available. with various laryngoscopes, fiberscopes, and face masks along with LMA. So coming to the different tubes we have been using, flexometallic tubes are the mainstay. The North Pole tubes where we expect the patient will be requiring the tube for a longer time. And microlaryngeal tubes are used when there is pressure effects due to compression of the gland. And whenever it is available, this NIM tube has come up, can be used in cancerous patients having cancerous growths. So this is the crux of the airway management to explain here. So we have this plan A, B, C. First plan A is to secure the airway. There are 4 basic management choices here. First is awake technique, where we are securing the airway before the induction. We have not induced the patient, but by other technique, we are trying to secure the airway before. So which is most commonly, which is done by where there is a very large mass of gland. There we are doing it by awake fiber optic bronchoscopic intubation. We do in retrosternal goiter, huge multinodular compression. Here the advantages, it's awake intubation, and we are putting the tube beyond the obstruction with visualizing. And the disadvantage is to pass in the airway of small caliber where there is very large thyroid compressing on the airway and decreasing the lumen. So there it can give rise to clot in the bottle effect, and it can give rise to complete obstruction. And if we are giving the airway blocks with local anesthetics, that can also worsen the obstruction. This is a case which we have done in our institute recently. We could intubate the patient with FOB with a lignocaine nebulization and just light angiolysis with little midazolam. We could intubate the patient. Then coming to the other awake choices, it is done under, as I told you, with lignocaine infiltration and regional analgesia also. And awake direct laryngoscopy, which can be done with video laryngoscopy also nowadays. Like it is a big chunk of cases are done with that technique. And in very severely compromised airway cases, of course, awake tracheostomy with expertise has to be done. And where the goiter is extending up to and compressing up to the carina, then CPB is standby. Where there is mediastinal mass syndrome like effect, we have to consider that. And wherever the trachea is compressed more than 50% in CT along with the symptomatic presentation, there this kind of precautions will be required. And coming to the other technique where we are putting the patient to sleep, after induction only we are proceeding. We are securing the airway, that is known as the sleep technique. There we are pre-oxygenating the patient for a longer time. We have to pre-oxygenate, and we have to induce mostly with volatile induction agent if we are planning to maintain the spontaneous breathing. If we are maintaining the spontaneous breathing, then we have to avoid the CIC. We cannot intubate, cannot ventilate scenario anytime. We have to be prepared for that. And if we are planning to ablate the breathing, that is by short-acting Soline also can be given, and then that makes the intubation comfortable. And then after putting the tube, then we go for the long-acting relaxant, or depending on the airway scenario or the assessment scenario, we will decide about giving the long-acting relaxant if we are sure that we can have access to the airway later on, or we are not having any difficulty in passing the tip of the tube ahead. Then that time we give the long-acting. Otherwise, with short-acting relaxants, we can try first. So wherever there is severe compression, we go for inhalational induction without relaxant. And where there is large goiter without compression, then there is inhalational induction. We confirm the ventilation and we intubate after succinylcholine and antipolarizers. It is said that propofol can cause airway collapse. So when we are using a large amount of propofol, we have to be careful. Propofol can be used while just doing the direct laryngoscopy, just to visualize also, along with nebulization with lignocaine. And into the other out of the four that we discussed, coming to the invasive and non-invasive airway. Invasive airway, of course, endotracheal tube and tracheostomy are the options. Endotracheal tube is the most common option. Tracheostomy can be elective or can be emergency, which is difficult, but has to be done, then has to be done. Then coming to the face mask ventilation and laryngeal mask airway, usually in some patients, laryngeal mask airway is put, and through that the fiber optic is forwarded to check out the compression and the narrowing of the lumen ahead. And then coming to the fourth management option, that is direct indirect laryngoscopy. Direct laryngoscopy, most cases of goiter is usually get intubated with direct laryngoscopy. It is seen by a very large study by Swadhyay et al. They say that if the neck circumference is within 60 centimeters, the range is 47 to 80, then most of the patients get intubated. And IV induction can be done with conventional direct laryngoscopy in experienced hands, usually in tertiary center. It can be managed well. So with experience, this can be managed well, and the quick decision has to be taken. And indirect laryngoscopy is done wherever there is predicted difficult intubation or ventilation, like it can be done with FOB or video laryngoscopy. Then further decisions regarding the caliber of the tube, about the type of the tube, will be decided.
Lipika ma'am, sorry to interrupt you. It has been already more than 35 minutes. So please, can you little bit rush through?
Okay,
Thank you so much. Yeah.
Then coming to rigid bronchoscopy, it can salvage a collapsing airway, and it is placed beyond a mid-tracheal narrowing or into a patent mainstem bronchus, and we can ventilate through side channel of or place a ETT through it. Okay, these I'm just going ahead. Coming to the positioning, all these points are to be kept in mind. As we know, these are the intraoperative monitoring which we do, and then all these help us to identify the thyroid storm. And what are the intraoperative complications? They are bleeding arrhythmias, airway compression, intratracheal tumor can give rise to obstruction of tracheal or bronchial lumen, and of course the most dreaded thyroid storm. So these are the concerns in extubations, like we always expect the patients to have a smooth awake extubation. So steroids and visualizing the vocal cords, now it is replaced with USG imaging, and there are reports of after surgery and observing the vocal cords also. So these are the precautions we take usually during extubation. And this is the post-op analgesia. Usually we go for infiltration and superficial cervical plexus block and NSAIDs, and usually acetaminophen is enough. So these are the causes of airway obstruction. Coming to the quickly into the post-op, immediate post-op problems of glottic edema and neck hematoma, which is usually seen immediately after extubation. We treat by head-up position, nebulized epinephrine and systemic steroids, 100% oxygen, and always reassess and intubate. And if it is recurrent laryngeal nerve injury, then usually they present with aphonia, airway obstruction, stridor, and hoarseness. And then we observe them and take care of their breathing. And coming to tracheomalacia, here it is cuff lick test. We know what it is. It has to be negative. If it is negative, then we have to delay extubation, and we have to do the extubation over the airway exchange catheter. And as we all know, if there is presence of hypocalcemia, we can make out within 48 hours. It is most common after 24 hours post-operatively, and we have to detect and treat. And usually we look at the QT prolongation and worst case sign and procedure sign in these patients and look for stridor. So why is thyroid status and timing of surgery important? Because there is this thyroid storm. So what is thyroid storm? It's an acute life-threatening syndrome due to an exacerbation of thyrotoxicosis. It's an infrequent condition now, but if it happens, then we must diagnose it early and we must treat it effectively. So the factors precipitating the thyroid storm are infection, acute illness, and non-thyroid surgery in hyperthyroid patients. and anybody who is not prepared well for the surgery, and discontinuation of antithyroid medicines. These are the signs and symptoms like the increased temperature, marked tachycardia, hypothermia, heart failure, tremor. These are the main features in an anesthetized patient. And I just want to mention that this Burke-Watersky point scale, that is a 45 parameter score indicator, like this mostly covers the thermoregulatory dysfunction and CNS and GI and hepatic. So along with that, the elevated FT3 and FT4 is a prerequisite, and we have to keep on adding the points and check for the scoring if the patient is going into a thyroid storm. So the specific therapies are, as we discussed before, beta blockers, antithyroid drugs as the first line of treatment along with hydrocortisone, and second line of therapy is plasmapheresis, oral T4, T3 binding resins, cholestyramine can be given, or lithium in patients who can't take iodine. And supportive measure is cooling. So it is a medical emergency and we have to treat the precipitating factors also. So to conclude, large goiters present for thyroidectomy are challenging for us, and difficult airway and physiological changes are challenging to manage. Adequate optimization with antithyroid drugs is essential to avoid thyroid storm. And awake FOB is most commonly done to secure the airway. BL-scopy with reinforced flexometallic tube is preferred mostly. Thyroid storm is a life-threatening complication and can occur even in patients on antithyroid medications. It must be promptly recognized and treated. So there is a need for clear planning, inbuilt protocol for management of difficult airway, and anticipation of complications along with their early identification and prompt treatment are the key to successful outcome for this kind of patients. So these are the questions which can come for this topic. Thank you for patient hearing.
Thank you so much, Lipika ma'am, and thanks for considering our request. There is this one particular question which I feel is important, so I would like to take this in spite of having time lag. How do you do tracheostomy in big thyroid goiter?
Yeah, that is usually by lifting up till now we have not got into this kind of situation, but we have done it for very huge cystic hygroma patient, in a pediatric patient, I remember, where they had to, of course, the tracheostomy takes time. For such kind of thyroid patients, till now, I have not experienced anybody doing it, even though everything is ready. But we had seen for the front of neck access, front of neck fauna, front of neck airway access is very difficult. But they can manage to, it needs more dissecting and it needs more experienced people. It can happen, but it takes time, and the hypoxia can happen. So that's why always keep a long, always HFNO policy, which the principle which we follow, keep a long measuring this, keep a long, in the nasopharynx, keep a oxygen source, a tubing, deliver this, then they don't desaturate at least till that time. They don't become hypoxic.
Okay.
It takes time. Yeah.
Preparedness
In
is the
expert
key.
hand, it takes time.
Yes.
Yeah.
Okay. Thank you so much, ma'am. So I would like to proceed to our next speaker today, Dr. Sandeep Diwan, and really thank you for him, to be patient till the end. So I would like to introduce him. Yeah. Okay. I'd like to introduce Dr. Sandeep Diwan. He is a consultant anesthesiologist at Sancheti Hospital, Pune. His consultant Department of Department of Anesthesiology at Sancheti Hospital, as well as academic head of EORA. He is academic director and research head and renowned faculty at various national and international conferences. He has multiple publications, especially in the cadaveric research work. So I would like to invite Dr. Sandeep Diwan for upper extremity blocks. Welcome, sir, and you can start sharing your screen.
Oh, thank you, ma'am. Can you hear me? Am I audible?
Yes, sir, you're audible.
Yeah, thank you, Sachin, and thank you, Dr. Bhalerao, for that this invitation. And I would like to start with this. Is my slide visible?
Yes, your slide is visible and you are audible as well.
Okay, fine. Thank you so much. So this was regarding the upper limb blocks as has been suggested to me. And so welcome to this particular PG assembly. And these are the topics that I would like to cover: the interscalene, supraclavicular, infraclavicular, and axillary. So what are the primary goals when you are looking for a block is a perfect anatomic orientation, a precise needle tip placement, and adequate volume of local anesthetic agent. We know about the brachial plexus, as the brachial plexus, it is sandwiched between the interscalene muscles, and they form the superior trunk with the C5, C6, the C7, and the C8, T1, they form the inferior trunk. So this particular area is the interscalene, the block at the interscalene area, while this is the infraclavicular, and this would be the supraclavicular. The axillary is where these nerves are, the peripheral nerves, the musculocutaneous, the median, the radial, and the ulnar. So these are the three different nerves. So paresthesia is obsolete. We're not going to discuss about that. And we are going to be very specific on a few areas, like the focus would be on neurostimulation in the interscalene and infraclavicular, and ultrasound in the supraclavicular and the axillary area. So neurostimulation, now this is interscalene, where you can see the needle is being placed at the level of the interscalene. The two fingers are palpating the interscalene groove. The needle is at right angle to the interscalene groove. And once the needle enters, you will see a small pop with a resistance. And once the needle is close to the superior trunk of the brachial plexus, you will always find the deltoid and the biceps contraction. That's the endpoint. At 0.4 milliamperes and not less than that, you can inject 20 ml of local anesthetic. And these are the blocks which are used for all surgical procedures which are in the vicinity of the shoulder joint. So with the superior trunk, which usually has the musculocutaneous nerve, the axillary nerve. So these are the two important nerves. Anesthesia has to be tested prior to commencement of the surgical procedure, and the incision is usually on the anterolateral aspect of the shoulder joint. A lot of relaxation is required, particularly of the deltoid and the biceps, so that they can get an access to the dislocated head and the shoulder. I usually use 0.5% bupivacaine, and sometimes I use adjuvant. It all depends upon the depth and intensity of the anesthesia as well. Now, if you look at this, where exactly the interscalene block is given, you will find the anterscalene muscle. You'll find the middle scalene muscle, and you'll see the C5 and C6, they have already formed the trunk, the superior trunk of the brachial plexus. So additionally, we will find the phrenic nerve, which departs at the level of C4, and it moves over the anterior part of the anterscalene muscle, and then it goes more medially. So if you're positioning your needle somewhere at this point, you will have 100% block of the phrenic nerve. But as you go down at this point, you'll see the distance increases, and then the incidence of phrenic nerve will be less. Additional block of the supraclavicular nerve will be required, and this can be blocked at the midpoint of the sternocleidomastoid. This is the sternocleidomastoid which has been retracted medially. So at this point, if you inject around 10 ml of local anesthetic just below the midpoint in the subcutaneous, in the connective tissue, you will block the supraclavicular nerves. Of course, with ultrasound, you see all these things, so you need not go with the landmark techniques. So most of the indications are trauma surgery, like the proximal midshaft humerus, acromioclavicular joint, and the clavicle. But for the clavicle nowadays, we use more specific block, that is the C5 block, or we use what is called as the SCUT block. And these both blocks we have published. And it has also been used for specialized surgeries like the shoulder arthroscopic surgeries and total shoulder replacements. In the past, I used to do awake shoulder arthroscopic surgeries and replacements, but the patient profile is different. And now we usually combine it with general anesthesia unless it's contraindicated. So this is just to show again the phrenic nerve which arises from the superior trunk or from the at the C5. So if your block is again very high up, you can see that they are enclosed in one sheath, and if you inject in this sheath, definitely the phrenic nerve will get involved 100% of the times, and that's why it is called as the sequelae of the block and not as a complication of block. There's a need for you to either decrease the volume of local anesthetic or you go still more corded. So this is usually with the help of ultrasound, where you can now identify the superior trunk and inject at this level so that the distance is more, and hence the incidence of the phrenic nerve block is very, very less. The next block would be the infraclavicular block, which is below the clavicle. And this is the block which is of my choice. And most of the times I use this with ultrasound nowadays, but previously with neurostimulation. Now, if you see, the needle is placed exactly vertical. The point of insertion is 2 centimeters medial to the coracoid process and 2 centimeters caudal to the coracoid process. So the needle, it pops through the pectoralis major and minor, and once it lands to one of the cords, it's usually the lateral cord, where you get contractions of the biceps, which has to be ignored, and you have to have these contractions like extension of the wrist, or there has to be a flexion of the wrist and the fingers. This is the point at which you inject around 30 ml of 0.5% bupivacaine for all the surgical procedures which are below the level of the mid-arm, or sometimes we have used it for shoulder surgeries, but quite less commonly. Now, this is a procedure where you have large incised port on the ventral and dorsal aspect of the forearm, which has been adequately anesthetized with the infraclavicular block. You can also insert catheters in these particular patients. So what is infraclavicular block? Now, this is the clavicle, and beneath the clavicle, you'll find the brachial cords, they are emerging. This is the lateral cord, that's the posterior cord, and you can see the bunch of the arteries arising from the thoracoacromial arteries. Now, this is very important because you are going 2 centimeters medial and 2 centimeters caudal to the coracoid process. This is the point where you are inserting your needle tip, which can be very, very close to the artery as well. Now, if you retract, you will find the subclavian artery from the vein, you will find the medial cord. So it's more commonly that the lateral cord and the posterior cord are the ones that you are encountering rather than the medial cord. Indications are continuous catheters. Usually I use for most of the elbow surgeries. This is with ultrasound nowadays, and for forearm as well as hand surgeries. Now, in cases such as like these, you don't have any endpoint for neurostimulation. So in this case, ultrasound would be more beneficial. So is ultrasound the answer? For example, now this is the pec major, and there's a very small pec minor. So once your needle pops through, you'll find that this is the artery. You have the lateral cord, you have the posterior cord, and you have the medial cord as well. Now, when you start injecting your local anesthetic, you see that the needle is placed just posterior, and you inject your local anesthetic. It will bathe or soak all the cords. You will usually find a septa there. You can see the septa, and you can just walk through that septa, and you can inject your local anesthetic beyond that. So 30 ml of 0.5% bupivacaine, which is given via ultrasound, can cover all the cords. We have come down with the local anesthetic volumes. We are now giving around 20 ml for the infraclavicular block. So ultrasound for the supraclavicular is more important because you can see that this is the corner pocket is this one, which is the angle between the subclavian artery and the first strip. And you can see the grape-like structures, which are all the brachial plexus elements. You can also see the needle, which is very finely placed at that point, just going towards the corner pocket. And I would like to inject local anesthetic just above the first strip and lift the brachial plexus so that I can advance my needle into that pocket. So after creating a pocket, you are very safe so that you don't have any paresthesias thereafter. So it is usually around 10 ml in the corner pocket at that point, followed by 3 ml in the middle trunk, somewhere at this point, and then in the superior you have 3 ml. So we have come down from around 25 to 30 ml with landmark to around 15 to 16 ml, where all the brachial plexus elements are soaked with local anesthetic agent. So if you look at the cross sections here, which we have done ourselves in Graz in Austria, you'll find that this is whole the brachial plexus, what you can see. This is the first strip, which has been already depicted. That's the subclavian artery. So the angle which is formed between these two is the corner pocket. So your needle has to go and has to be placed finely here to take care of the inferior trunks, which would not be otherwise blocked. Then you have to withdraw the needle and then advance in the middle trunk at this point, withdraw and advance in the superior trunk at that point. So what you see are these are all the fascicles, and this in between the fascicles is the connective tissue. So if you would be giving with the anatomical landmark, your needle would be placed here, and there would be paresthesia. If it just encounters this part, you withdraw the needle and inject your local anesthetic agent. And this is the reason why we don't get much of peripheral nerve injuries with the even with the landmark technique. Indications are humerus, elbow, forearm, and hand. And the alternatives could be intraclavicular, axillary, and forearm blocks. Coming to the cross-section of the brachial plexus in the axillary area. Now here what you find is the humerus, and medial to that will be the coracobrachialis muscle, which hosts the musculocutaneous nerve. This is the artery. You'll find a lot of veins as well here. The median nerve will be superior, the ulnar nerve will be posterior, and the radial nerve would be inferior to the axillary artery. So naturally, when you do it with the landmark, you will palpate the axillary artery, and then you'll go superior to that and inferior to that and block the median and the radial nerves after obtaining the contractions. And the musculocutaneous nerve, you will lift the coracobrachialis and try to inject a volume of local anesthetic in the musculocutaneous for the musculocutaneous nerve block as well. For the ultrasound, you're going to go right over the top, block the median, withdraw, then go below, block the radial, then go beyond that, block the ulnar nerve. It becomes very easy with the ultrasound techniques. Now, after we inject for the median nerve, 4 ml each for median, ulnar, radial, and then for the musculocutaneous, we inject 3 ml, a total of 15 ml. So we have come down from a volume of around 30 to around 15 ml now. And here we will find that the nerves here, the ulnar nerve, the medial cutaneous nerve of arm, and that is the median nerve, which is going just above the axillary artery, and this is the humerus. So it becomes very easy, and with the ultrasound, and nowadays we have replaced all our blocks except maybe the deeper blocks like the lumbosacral plexus blocks, which I relish doing it with the peripheral nerve stimulator. Indications are forearm and hand surgeries. So this was the timeline when we started using paresthesia in 94, followed by loss of resistance 1999. The paresthesia was used basically for the supraclavicular blocks, the loss of resistance for the lumbar plexus. Then arrived neurostimulation in 2001, where we started using it for a plethora of blocks. The stimulating catheters, though they were quite costly, we used it for our academic purpose. And ultrasound, I started doing it in 2008. And since then, we have been using ultrasound as well as neurostimulation. Dual modality can be used at times, not necessarily all the times, particularly for deeper blocks when you're not able to see or visualize the nerve appropriately. In that case, you have to use neurostimulation, usually for lumbar plexus, sacral plexus, and sciatic blocks. So more commonly for the lower limb blocks, and now very less commonly we use it for the upper limb. So how do we get there? You have to have a strong desire. You need to dedicate the entire career for that. You need to be very much determined and disciplined in your practice. This is how that you get very close to all these things. And you need to practice regional anesthesia with great care and caution. So thank you very much, Pimpri Chinchwad branch, for giving this opportunity. It's a very short one, but I thought I should conclude it in a very short and sweet way. Thanks a lot.
Thank you, Dr. Sandeep. And it was real sweet and short, and I loved those 4Ds part of your presentation. And I would like to, go ahead, Sachin.
You just complete it.
Okay. There's one question from Dr. Chaya. So which all adjuvants can you add for prolonged blocks? And what about using other local anesthetics like L-bupivacaine and ropivacaine?
So regarding local anesthetic, I have been using bupivacaine for a very long time, so I'm very much for it. I don't want to really move away from it. That's one thing. The second thing is about adjuvants. I use clonidine because it has been approved, and there have been a lot of studies regarding peripheral nerve blocks. But recently, I have started using dexmedetomidine because it's neuroprotective. In case of peripheral nerve injuries, definitely there would be some inflammation, and there are few studies which mention that dexmedetomidine, it reduces the inflammation and thus would reduce the peripheral nerve injuries. Regarding dexamethasone, which many of us use, I mean, there are also many in literature as well. But I think the perineural injection is equivalent to intravenous injection of dexamethasone. So I'm really unsure about this particular. So for now, I use clonidine.
Sir, the dose of dexmedetomidine in the blocks?
So I use 12.5 micrograms to 25 micrograms, 12.5 in the upper limb and 25 in the lower limb.
Okay, thank you, sir.
Okay, thank you very much, sir.
Thank you.
And here our academic session is, I declare it is concluded. There are few instructions will be given by Dr. Seema Suryavanshi with vote of thanks. Meanwhile, I would like to display the support given by our pharma companies and would like everyone to have their attention for couple of minutes. Thank you so much. The screen is visible.
Yes.
So that was by Aquarius Life Sciences, and this is the video by Neon Life Sciences. Okay.
Is it
So
all,
thank you,
Varsha?
everyone. Yeah, I would like to call upon Dr. Seema Suryavanshi for vote of thanks.
Okay. Thank you, Dr. Varsha. Once again, as a Secretary of Society of Anesthesiologists, I would like to thank many members. I thank Dr. Venkat Giri, sir, President ISA National, who had given us the responsibility and sponsored this national CME. Sir, we really missed you on Saturday, though you were present there virtually. And I really want to thank you for joining us today in this event. Thank you, sir. I would again like...
Sir wants to say something. Yeah. Sir.
It's my
Yes,
pleasure
sir.
to be with you. I missed that day. Today I full time. I enjoyed the CME. Thank you.
Yeah.
Yes.
Thank you.
Thank you, sir.
Yes. Thank you, sir. Thank you so much.
Yeah.
Thank you.
Sir, I hope we have done justice to the responsibility what ISA National has entrusted upon us. We would really like to have a feedback from you, sir. Thank you, sir. I would again like to thank Dr. Manisha Katikar, Madam, the President of Maharashtra State Chapter ISA, once again for encouraging us to take up this event at Pimpri Chinchwad. She has been constantly with us and guiding us throughout right from the beginning. Thank you, Madam. I take this opportunity to thank all our respected speakers who have really presented a very informative lectures and wonderful presentations, especially tailor-made for the postgraduate students. It is such that I have been receiving many calls and many messages like we want the PPTs of the speakers and everything. The presentations of all the faculties were really very good. I would like to thank Dr. Sawant Madam, Grewal Madam, Divan Sir, Karne Sir, Minakshi Sundaram Sir, Today Madam and Lipika Madam for taking out their valuable time for this event. Thank you everyone. I thank Dr. Sachin Wagh and Dr. Varsha Kurade, our executive committee members from SAPC for a wonderful coordination. Once again, we are very thankful to all the delegate students as well as the consultants who have participated in this 3-day academic event and made it successful. All your queries, the delegate students, we will keep on answering. So just stay with us for a few days on the group also. And you are going to receive the certificates also, so don't worry about it. We are thankful to the DigiShield for the technical support. Thank you, everyone.
Just 1 second, Dr. Anjali Bhure Madam, coordinator for ISA National PG Assembly. She was supposed to join, but she had a very hectic 2 days being with us 2 days back. So she is not keeping well. Her presence was there. Actually, she had told me I would like to join, but maybe she's not well. That's why she could not join. But thank you, Anjali Madam, also for that, for her guidance. Thank you. Thank you, all delegates. Thank you so much.
Thank you.
Yeah, we can conclude the session, I think.
Thank you, sir.
With permission from Venkat Giri, sir.
Thank you. We can conclude. Thank you very much.
Yes.
Enjoy
Yes,
the class.
Good night, everyone.
Yes.
Good
Thank
night.
you, sir. Thank you so
Thank you.
much.
Thank you so much. Thank you so much. All of you.
Thank you, Sachin, and thank you, Varsha. It was nice anchoring. Thank you so much. And thank you all.
मॅडम तुम्ही प्रत्येक वेळेस आम्हाला थँक्यू म्हटाल.
And thank you, Dipen, for your valuable support. Thank you so much.
Dipen, thank you so much. And Maya ma'am, Sumit sir, Seema ma'am, thank you so much.
You can,
It's all fun.
yeah.
Fantastic.
Dipen, you can close the session, no problem.